All right, well, good afternoon, everyone, and welcome to the House Committee meeting, Technology and Communications regarding House Bill 1925. Before we get started, Noah, can you please call the roll?
Chair Cerisi, Representative Carroll, Representative Curry, Representative Davidson, Representative Doherty,
Here.
Representative Inglis, Representative Kozarowski, Representative Napoleon Nelson, Representative Powell, Representative Prokopiak. Here. Representative Rivera,
Here.
Representative Rusnak, Representative Siegel,
Share this with Dan, okay? Keep in touch. Okay, okay. Thanks for,
Representative Takak, Representative Venkat, Representative Waxman, Chair Ortitai,
Here.
Representative Dorsey,
Leave.
Representative Day,
Leave.
Representative Ecker,
Is on leave.
Representative Gatos,
Leave.
Representative Irvin,
Here.
Representative Ledbetter,
Leave.
Representative Eric Nelson,
Here.
Representative Reichard,
Leave.
Representative Rigby, Representative Shalaba,
Leave.
Representative Stair.
Virtual.
virtual.
Thank you. So before we get started, I want to let everyone know this meeting will be recorded. Please silence your cell phones. We'll also be taking video, both video and audio in this meeting. All the testimony can be found in the packets or with a QR code. The public hearing today is on House Bill 1925, which is introduced by Representative Venkat. Before we continue, I'd ask Alice to go over a brief description of the bill and also how we're going to proceed.
Thank you, Mr. Chair. House Bill 1925 sets guardrails on the use of artificial intelligence in the healthcare industry, including requiring health insurers and healthcare providers to disclose the use of artificial intelligence and have an individualized assessment by a human decision maker in insurance utilization review and clinical treatment decisions. Today's hearing will be broken up into 5 panels, including representatives from the insurance and tech industries, public policy advocates, physicians and nurses, hospitals and health systems, and the Pennsylvania state government. In addition to the testifiers you will hear from today, we have also received written testimony that was submitted for the record by the Pennsylvania Department of Health, the Pennsylvania Department of Human Services, America's Health Insurance Plans, TechNet, the Hospital and Health System Association of Pennsylvania, AdvaMed, Highmark Health, and Representative Greg Scott.
Thank you. Before we get started, I just want to say a couple words. First of all, for anyone that's testifying, please do not read your testimony. We have it in front of us. If you can summarize it, we do have a 3-hour hearing, so the more we can have a conversation and let the representatives ask questions, the more beneficial it is to everybody. But again, if you could really not read it, it would be much more beneficial to us. This is a very important subject matter that we're looking at today. It's something that as we move into AI and we move more into the future, we need to understand more of what happens. And we are blessed in the House to have a physician who has worked in the hospital system, in the ER, saving lives on a daily basis, to be able to come up with the legislation. And I want to introduce our Representative Venkat today to start us off and give his testimony before we hear from anyone else. So thank you again, and the floor is yours.
Thank you, Chair Cerisi, Chair Ortitai, members of the Communications and Technology Committee for picking up and holding a hearing on House Bill 1925. I think we can all agree that artificial intelligence, AI, is a paradigm shift in terms of how healthcare is and will be delivered in our Commonwealth. There's no question about that. In my practice in the emergency department, I've already seen that related to AI and the use of clinical documentation. But this is a very different technology and a very different situation than other developments in healthcare. And the reason is threefold. AI is autonomous, it purports to approach human intelligence, and is black box related to its reasoning. We don't have reproducibility like we do when I'm looking at a CT scan or interpreting a lab result. In many ways, it is similar, though not quite at the level, as decision-making that happens on a daily basis in healthcare by clinicians. And we already in Pennsylvania have decided, rightly so, that there needs to be legislation to regulate healthcare and how it's delivered. We have licensure of clinicians, we have liability laws, we have safety, we have transparency and anti-discrimination as examples of this. So the question is, with artificial intelligence being rapidly deployed in the healthcare system, do existing laws meet the need of the regulations and the statutes that we've already created to regulate this circumstance, or do we need something more? My co-sponsors and I want to give a shout out to Representatives Hogan, Khan, Kozarowski, and Scott, all of whom were instrumental on these issues and putting together this legislation, is that emphatically we do need to have new legislation. And the reason is that we simply do not have transparency to patients and the public when artificial intelligence is being used. We don't have the ability to see whether human decision-making is not being superseded in the use of artificial intelligence, and whether those who are deploying artificial intelligence can reproduce to regulators and to us in the General Assembly and ultimately to the public whether existing laws on discrimination, safety, and privacy are being met. I want to thank all the testifiers who are going to be speaking to us today, and I had a chance to read through the written testimony, and I would highlight that the public advocacy groups, the patient advocacy groups, the clinician groups, and to a large extent, departments within state government seem to be supportive of an effort to create an artificial intelligence in healthcare statute. Where I think the questioning, I hope we'll see from the committee today, is on the issue of, should we be doing this at the state level or should we be deferring to the federal level? And I would highlight the written testimony from Commissioner Humphreys, of the Insurance Department, who pointed out that efforts to create model legislation for insurance especially has stalled because of conflicts in that process. And unfortunately, we've seen at the federal level that that is not coming together, that this type of legislative effort is not coming together, which I think leaves us here in Pennsylvania having to act. And I think the fundamental question that all of us should be asking, given the nature of artificial intelligence, is if it were you, your loved one, or a member of your community who was receiving health care, would you want anything less than crystal clear transparency, individualized decision-making, and proof that you are minimizing risks to privacy, safety, and discrimination in the delivery of that health care? And I think the answer, again, emphatically is yes, and I look forward to the testimony today. So thank you so much, Chair Cerisi, for the opportunity to be here.
Thank you. Please join us up here. I want to acknowledge that Representative Takak is online, and Representative Rosnek joined us here. Anyone else come in? Kozarowski's here too? Oh, he's over there. All right. And also, I wanted to acknowledge Jason Ortizai. I don't know, you said you had nothing to say, so I apologize before for not acknowledging you, but you may want to say something now.
No, that's fine. I figured with a hearing of this length in the panel, let's just get to it.
But I'm sure everybody will be happy to see that. So our first panel will be J.B. Branch from Public Citizens and James Sullivan from Healthcare Information and Management System Societies. Either one of you could go first. Is your mic on? Yeah, there it is.
James Sullivan with the Health Information Management Systems Society. I'm an executive board member and past president of the Pennsylvania Keystone chapter of HIMSS also. And in the industry, I work as a strategic advisor to the healthcare information technology industry. A little bit about HIMSS, and this is a highlight of our written testimony, which is also submitted, but I'll read from my outline. About HIMSS, the HIMSS Information and Management Systems Society is a global advisory and thought leader and member-based society committed to reforming global healthcare ecosystem through the power of information and technology. As a mission-driven nonprofit, HIMSS offers a unique depth and breadth of expertise in health innovation, public policy, workforce development, research, and analytics to advise global leaders, developers, end users, patients, and influencers on the best practices in health information technology driven by health equity. Our key points, and we're going to talk about what AI isn't and what it is. AI is not new to healthcare, but it has and continues to evolve. A single monolithic category, but a variety of tools that exist on a spectrum of maturity and capability. It is confused by marketing hype and a desire to recast established machine language technologies as AI. AI encompasses a broad spectrum from imaging applications in use for decades with volumes of clinical studies and large language models used informally by health system staff without oversight or evidence of suitability. It's essential to understand the economic value of AI as the healthcare system struggles with sustainability. The market is in an unprecedented frenzy and near the peak of the generative AI hype cycle. Everyone is focused on AI and everyone is doing something around AI. Cutting through the noise and finding things that are worth doing is a key. One of the things that, one of the points, the main points that HIMSS stands behind in any type of AI technology, when there's any recommendation coming from a machine logic like AI, is to keep a human in the loop, a clinician, a doctor, someone that is the trusted caregiver of the patient. The idea of AI is to be able to sort through informatics, data signals, data points, things that a human may not be able to find either quickly enough or may be so embedded that AI can pick it out quicker. But when those recommendations are surfaced, it's important that a human always be in the loop to advise and be the final arbiter of what is prescriptive about delivering health care and what's in the best interest of the patient. If a human is ultimately responsible for the content, and in many use cases, this should be clearly communicated in training and policy. Policy frameworks for AI in health and human services. We're looking at recommending for guardrails and safety, establishing policies that address unique use cases for AI patient safety and mitigate harmful biases, risk-based regulatory approach to consider intended use cases, look at the risk levels, the types of AI intervention required, and potential impact on patient outcomes. The development and deployment focus is for continuous monitoring and adaptation from development through deployment, ensuring that AI evolves with data. And again, as informaticists and technologists and technicians on the technology side, on the information technology side, it's important that we're supportive of the clinicians and of the processes and workflows that go into patient safety and delivering effective patient care on a timely basis as quickly as possible. And AI is going to help us do it, but again, human in the loop is paramount. Our recommendations for safety policy and frameworks: monitoring and performance evaluation, thoughtful monitoring post-implementation, meaning after we get things up and running or after an organization gets their AI initiatives up and running. Ensure the continuous oversight from all parties to safeguard patient. Everybody in the loop, everybody in the process, everybody involved in that continuum of care for the patient should always be involved in monitoring what's going on, of course, with the patient overall from a status, from a clinical status position and point of view, but also to ensure that the patient's safety is always at the forefront. performance and feedback mechanisms to implement technologies to evaluate AI output, inform developers of any deviations from the expected results. So again, human intervention to take a look at all of the output and the recommendations coming from AI with a keen sense for recognizing if things seem to be out of sync or out of bounds at any time and are drifting in one direction or the other. And that doesn't always mean necessarily that something's wrong. That could mean that AI is steering you in a direction that needs to be paid attention to. So again, human in the loop, it's important to pay attention to these indicators coming out of AI. Organizational competencies assess whether organizations have the strategy and the team to manage AI safely before adoption. This has to go with self-assessment and maybe some outside help for assessing the maturity of your clinical organization, your state or public health-based organizations, to make sure that you are understanding your readiness and your own maturity to evolve with your AI tools and actually apply them correctly. In workforce development and public policy, data governance and stewardship models are of the utmost importance for your IT staffs as well. Accessibility and equity in AI, looking for non-discriminatory access. Ensure AI systems do not restrict healthcare access based on protected characteristics such as language, ethnicity, disability, and socioeconomic status. Focus on vulnerable populations. Commit to addressing disparities from marginalized groups in the application of AI in healthcare. This is important for the contextual aspects of how you apply AI to the well-being of a patient, the patient's own conditions, the patient's own context in which they live and work. This is important for understanding this contextual awareness. Again, to be that human in the loop, to be oversight for the patient safety, the patient environment of patient care, and to work with AI to allow AI to help guide you, but not override you in what you're doing for patient care. Human oversight and transparency. HIMSS Global AI Policy Principles recommends that clinical decisions involving or influenced by AI and machine language should be made collaboratively between humans and the technology, as I just mentioned, to the extent necessary to preserve patient autonomy and the comfort to improve clinical outcomes and care outcomes, both for the patient and for the clinicians, by the way. This is to improve the environment that the clinicians work in, instill confidence and trust in the environment they're working in, and again, to allow patients to have trust and confidence in the care that they're receiving. Providers should use tools that are determined safe and appropriate by governing bodies to provide the highest quality in clinical care, including AI-enabled systems. If fully autonomous systems that make independent decisions in patient care will be used, patients should be informed upfront and thoroughly prior to receiving care by these AI-enabled systems. In conclusion, the development from AI in health and human services necessitates a comprehensive policy framework that ensures safety, explainability, and equity while investing in workforce competencies and robust data governance. The strategic approach will facilitate better health outcomes and patient safety safeguards and interests for both the patients and the clinicians. Thank you.
Thank you very much. JB?
Thank you, Chairman Searcy, Republican Chair Ortatai, and committee members. My name is JB Branch. I'm an artificial intelligence policy expert at Public Citizen. We're a national nonprofit with more than 1 million members and supporters nationwide, working to defend democracy, resist corruption, and challenge corporate greed. I'm going to take a note from Chairman Searcy and skip over some of these notes and just focus on some of the main points here. You know, I speak with a lot of legislatures across the country, and I actually just last week testified before the Congressional House Committee on Financial Services on artificial intelligence. AI is a big deal. It's going to continue to be a big deal. It's a focus not just in this legislature, but within Congress and states across the country. There was some talk earlier with regards to federal regulations, and right now there are no real federal regulations on AI. That's why advocates like myself have had to lean on and really look at state leaders to lead the way. It might be no surprise to anyone here, but Congress simply doesn't have their act together when it comes to this topic. Polls show pretty consistently that Americans want some form of regulation on AI. And there have been multiple attempts to try to preempt state AI regulations multiple times over. And the polling, again, consistently shows across the United States, regardless of political ideology, that people want protections, consumer protections when it comes to AI. I think in large part that is because Americans have a lot of buyer's remorse from listening to social media companies in the late 90s, early 2000s, when they basically said, don't worry about it, we're the experts, just let us regulate ourselves. And what we're seeing as a result is rampant misinformation, algorithms that harm children, young girls being pushed towards anorexia, other kids being pushed towards suicide because we allowed these tech companies to regulate themselves. And so, state legislatures have to be the adults in the room if other folks aren't going to step up. This bill in particular touches on a variety of issues that Public Citizen is really high on, and it's very important to consumers. One being transparency. It requires disclosures for folks to realize that they're interacting with AI. That's huge because more and more, as we see, folks are having difficulty determining whether or not something is AI or not. It's easy when you call CVS and you're screaming on the phone because you're saying, just get me to a pharmacist, I don't need this loop. That's easy, but it's gonna become increasingly harder to determine what is or is not AI. And part of that is because a lot of companies view this as a means to basically cut a lot of jobs. The next push in AI is going to be agentic AI or AI agents. And this is sort of the dream for a lot of these companies where we can just start automating tasks left and right, and these agents are going to be able to take care of those tasks. There's a huge assumption in that, and there's a huge assumption, particularly with a lot of folks who are really high on AI, buy into the AI hype. And the one assumption that I'd like to just sort of flag is this assumption that AI, artificial intelligence systems, will just have a true north and continue focusing on that true north and continue to get better. What they don't flag is a concept referred to as AI drift. And what AI drift is, essentially, you may have heard of these instances in which these algorithms result in discriminatory outcomes. Or most famously, there's been several teens who've harmed themselves by suicide because these AI systems encouraged them to do that, and there was no human in the loop, like my colleague said, to intervene. Some people might ask, well, why would you allow a product out there into the ecosystem that is going to allow something like that to happen? There may or may not be guardrails on some of these things, but what ultimately ends up happening is that these AI systems are focused on what I refer to as their goals. And they try to get to their goals as efficiently, as quickly as possible. And that's where you see this AI drift that occurs. And so one of my concerns with these AI agents is that almost assuredly, if they're working from a corporate background, their goal is going to be maximizing profits. And the concern with that is going to be, if they're not concerned about the healthcare consumer, if they're not concerned about the consumer that's right before them. And with enough data over time, they start to drift away from what we would consider core consumer rights values and start to drift away into this sort of AI slop where consumers start to get harmed. We're seeing that pretty consistently across the board. Particularly when it comes to AI in healthcare, there have been a variety of studies that have shown, it's not infallible. And that's why we do need humans in the loop. That's why we do need people to intervene when things go wrong. There's no industry that requires empathy more, I would argue, than the healthcare industry. I mean, there's research that even shows like just a hug as a patient can actually improve health outcomes. And so to strip that empathy away, the potential patient advocate from that system, I think is just harmful in general. But there's a variety of studies that have shown that, some of these AI systems replicate some of the bias in their data. That includes bias that results in misdiagnoses, unequal treatment for women, unequal treatment for Black patients, individuals with disabilities, and as well as individuals in rural communities. I'm from Lebanon, Pennsylvania. I grew up there. I'm a graduate of Cedar Crest High School. When I was growing up, we didn't have that many healthcare facilities around. And what's going to be sort of the talking point for a variety of healthcare industries is going to be, well, these AI systems are going to provide those folks that care. But I can assure you that what those communities need is they need real doctors. They need real nurses in their communities. They don't need that outsourced out to a robot. Additionally, this bill also includes provisions that touch on accountability measures, ensuring that any sort of decision is going to be reviewed by a medical professional. That's going to be increasingly important moving forward. There's provisions that speak to responsible data. In this age of AI that we're moving towards, data is the key. Data is the power. Whether that data is clean, whether that data is sloppy, and where that data exists. I worked with a school district in California, and they had an AI chatbot that had its servers overseas. That is a huge no-no. And so we need to know where this data is going to be incorporated at, where the servers are based in, because it's both a patient privacy issue, but it's also a national security issue, again, in this age of AI where data is incredibly important. Finally, just to wrap up, I think this is a very thoughtful bill. It's forward-looking. It's going to place Pennsylvania as a leader amongst a variety of states. There aren't that many states that have AI healthcare bills. So by pursuing this bill and moving it forward, the Commonwealth of Pennsylvania will automatically sort of be shot up as a leader in this area. It protects patients, enhances care, but most importantly, it's grounded in values, fairness, safety, and accountability, and respect for the people that we hope to serve.
Thank you both very much for your testimony. We have a question from Representative Nelson.
Thank you, Mr. Chair. You guys are the lead in a very long series of hearings. So I wanted to ask you a little bit about, Mr. Sullivan, you mentioned keeping human in the loop, and Mr. Branch, you talked about bias. And I would suggest that right now, there already is bias from humans that are in the loop, and those groups, Mr. Branch, you mentioned rural families, Black families. If we overregulate the ability to use data to develop customized treatment and put a human that may have their own bias, could we be doing Pennsylvanians a disservice? I give an example of integrating biomarkers with cancer treatment so that they can find an accelerated prescription that may help them. That would all happen faster, or those recommendations, not necessarily having a human at every touch point. So how do you maintain the balance in what many people say a system already has bias, where AI might help to remove some bias and maybe get better health care to people faster and cheaper?
So I think there's this misconception that AI is entirely objective and doesn't have biases, and there are biases that are already prevalent in AI just as a result of us having sloppy and biased data. But what I would say is that what this bill does is it's checking for that bias and requiring reports. It's checking in that bias in having those reports provided to be able to authenticate and check the accuracy of these systems. But then the other thing that I would say as well is that we should be trusting into these healthcare professionals. Now, to your point, can any professional have biases? Like, yes, like I concede that point that that is a possibility. But these professionals will be able to step in and be able to actually review the documentation beforehand. So I think that combination of being able to review these algorithms on sort of a yearly basis to ensure that they're producing quality outcomes in combination with healthcare professionals who know you, who know me, who know the patients themselves, to be able to provide them, the best quality advice after an algorithm provides whatever output it does.
I'd like to follow up on my colleague's comments. He made a couple of comments that he made very, very spot on. I think we're both on the same page with human intervention, human in the loop, and being able to find that, like you said, the balance in the technology here. It's absolutely true. AI can drift and develop its own bias, or you could already have human bias in the process. When you're looking at how to set up and regulate the technology, I think it's important to find that balance from a legislative point of view, but not to over-tighten the screws on AI guidance, because that could make it untenable and ineffective and probably unusable for a clinician as well. If there's actually too many rules and regulations to use AI without giving it room to breathe, develop trust amongst its users, it could be rendered untenable. But finding that balance is important from both the human side, the machine side, and the regulatory side as well. It's important that we look at points like governance, stewardship of the data. One of the things my colleague said that I found really key was responsible data, making sure that your organization is getting responsible data from the right places to feed correct information into your AI, but finding that balance between human intervention and having AI help mitigate bias that may be already introduced by a human in the loop to help balance that. It doesn't necessarily have to be nefarious bias either. This could be honest bias that AI helps us sort out, but it is finding that balance between regulation, human in the loop, and making sure that we keep an eye on bias. And my suggestion from our IT perspective would be it's important to take a look at your governance model, your stewardship model, and your transparency and how your organization looks at your AI.
Thank you, Representative Urban.
Thank you, Mr. Chair. Thank you, Mr. Sullivan, Mr. Branch, for your testimony. Mr. Branch, I really did appreciate your statement whenever you related to social media, where we said, well, we'll just let them regulate themselves and not have to worry about that. And we've sort of seen where that has taken us as a society. So I did have some concerns with regulation of especially state government regulating the AI into the hospitals. I always felt that they're there to do the best for the patients that they serve, and why should we actually be getting involved in the regulation of it? So I do appreciate that, and I will keep that in the back of my mind as we move forward in this hearing and also with this bill. But myself, coming from very rural Pennsylvania, and a lot of hospital deserts, maternity ward deserts, and everything with the health care condensing like that, in your mind, where would you see rural Pennsylvania benefiting by AI in the healthcare system?
So I'm from Schuylkill County originally as well, so I'm very much embedded in our rural community and also very sensitive to how we're aging as a population in Pennsylvania as well. In the rural setting, I think AI gives us a good deal of promise to engage the community, whether it be younger community, elderly community, rural community. As long as there is some sort of connectivity for your rural community, I think AI can be more engaging than technology might have been in the past. And I'm not sure if everybody is aware, too, in terms of information availability and distribution and access. Pennsylvania is actually one of the more mature data exchange and data sharing states in the nation. And we have about 5 of the more mature and well-sustained data exchange organizations operating in conjunction with the state for sharing information, make sure that data access is clear, concise, and available, and making sure that availability of information and distribution to the population is as available as it can be as well. So, so part of the answer to that question is looking internally to the capabilities that we already have here in Pennsylvania from the state's perspective on health information exchange and public health awareness in terms of information flowing in and out of the registries, but also very, very importantly, from these regional health data exchanges, health data utilities, as they're trending now to make this data available. They're becoming very engaging with the hospitals and providers from around the state, which allows them to be more engaged with the patient population to make information more accessible and actually have that outlet, from your PCP to help explain this and engage with your patient as well. It's kind of an entire infrastructure approach, but we are very fortunate in Pennsylvania to have that.
Yeah, thank you for your question. I would say that, one area in which AI can be particularly helpful is within the healthcare industry, would be sort of the paperwork of it all, quite frankly. A lot of nurses, a lot of doctors are inundated with just globs and globs of paperwork that they have to get through. And in part, this is what some companies are pitching, that AI agents will be able to help, make these processes more efficient. We see in some of this research, I think there's some folks who assume that AI is the equivalent of like having a doctor or having your own personal lawyer or something like that. But the research is bearing out that it's more like a junior level like employee. And so, I think something like summarizing patient notes at sort of a lower level could be particularly helpful to free up nurses, to free up doctors to handle more serious matters. But again, there's that need for the human in the loop, that need for review of those practices, because we can't just automatically assume that those summaries are going to be perfect, right? You wouldn't provide an intern, a 50-page booklet to summarize and just assume that they got it all correct. And that's kind of the way that we need to treat these technologies. Like it's not 100% new, but it is pretty new. And to that end, their outputs are not that of a doctorate or that of like a real attorney. They're sort of lower level staff that it needs to be reviewed with some consistency. And so that's why I think this bill's regulations in terms of reviewing for accuracy with a fairly regular basis is going to be key moving forward.
Thank you. Chair Titai.
Thank you, Mr. Chairman. I just want to get to a simple question. How is AI being utilized in the healthcare industry today? What specific uses is it being utilized for?
So it's being used in a number of areas now, and there's, the list is growing. So it's really hard to say, to answer your question quickly, that's not an effective way to approach.
You can hit me with
the
big ones, and I'm sure throughout this hearing we'll hear more and more about how it's being utilized and where we're going in the future, because this stuff does change pretty rapidly, as you guys know. So I'm just, for everyone out there and for the sake of the legislation and the hearing, just trying to figure out, all right, from someone watching at home, what's like, are we using it for chatbots? Are we using it for phone calls? Are we using it to make medical? Like, where are we at right now?
So I think there's 2 ways to answer that, and I'll try and keep it high level and simple. Exactly to your point, AI in terms of a chatbot and being conversational. There's conversational AI, where somebody's picking up a phone, a patient is picking up a phone and needs some advice on how to either traverse through the system, or they have a medical question where conversational AI can help direct that patient either to another inquiry with a doctor or possibly answer that question. So there is that area of it with, and that's already happening as we speak. On the clinical side, if we look at something that's imaging, for example, AI is being used heavily to try and help pick out data points within images, within lab tests, to say there are data signals and data points within these tests that a human might be able to pick out at some point, but again, it exposes it a lot quicker and could do a lot more things concurrently rather than linearly. So from a clinical perspective, AI is being engaged to help us look at data points, data signals quicker and expose that faster in a clinical setting and on a patient setting, looking at, for example, conversational AI to help a patient with a phone call get in touch with their PCP or get prepared to get in touch with their PCP. I'd say that's the best way to describe it from both the clinical perspective and the patient perspective. And you could go on from there.
Yeah, and I would also say, you know, consumers most likely to experience an AI interaction at a sort of customer service level, whether that's calling in. But there's also a lot of behind the scenes work. So things like healthcare insurance decisions are increasingly sort of being moved out towards AI. Doctor summarization of notes, medical summarization of notes, diagnoses. There's actually a lot of research showing that the combination between a doctor, but then also using AI is resulting in some really great diagnoses research. Data cleaning as well, so going through patient records and cleaning up all of that data. So it's very, very broad use cases for it.
And if I might add one more point to the points that are being made here, the contextual training of AI is really, really important. There's going to be different contexts in a clinical setting. There's going to be different contexts to train that AI in a patient setting. So, you know, it's important that we understand that there are different applications. It's not one size fit all. It's not the easy button. It has a lot to do with your maturity and your knowledge and your awareness of your own environment that you're working in. So very, very important, again, to keep the transparency through your organization so you get it as right as you can.
Representative Rusnak?
All right, thank you so much, gentlemen, for being here this afternoon. And my question goes back to the point of sloppy data and AI, you know, getting sloppy data as opposed to more accurate data, if I am thinking correctly about that. So my question to you, and in terms of Representative Ortizai, like for the people that are watching at home, that are trying to wrap their heads around this and they hear that term sloppy data, how is the sloppy data being filtered out in order to get down to the correct data? From a healthcare standpoint, we were always taught we needed to read peer-reviewed journals and articles and know that they were extensively, you know, researched and looked at by, you know, several experts along the way to make sure that the information that we were getting is accurate. So AI, I think, is a very useful tool because it can cut down on, you know, filtering, a human trying to filter through all kinds of information, but you're connecting the human to the AI. So how do we know that it's sloppy data, and how do you filter that sloppy data out? Will it learn it on its own, or is it reliant on the human to be able to filter that out?
Yes, thank you for your question. I think part of the problem is that this sloppy data that we're referring to, it's institutional. It's the data that we have, and that's kind of just it, full stop, right? And you can clean out, there's sloppy data in the sense that you might have incomplete data files or something like that, and you might try to patch things up to clean it up a bit, or you might drop a patient if the full record isn't there. But the data that we have is the historical data since we've been collecting it. And that's kind of some of the issues inherent with this, because it's going to replicate all of the biases that we've seen. A simple, like, straightforward example, you know, the medical symptoms of a woman experiencing a heart attack are very different from the symptoms that a man might experience, right? And so, many times over, their symptoms of a heart attack will not be perceived as a heart attack. It might be perceived as something else. And then mom goes home and it turns out actually it was a heart attack, right? And so that's the type of example, that's the type of concern that I have when we're talking about this data. We all have moms, we all have people in our family who we care of who are women. That is historical data that it's just there. Now, how do you try to clean that out? You may have engineers who go in there and might look at certain records and try to code that out. They might try to look at certain outputs and to put it very simply, kind of bend the algorithm in a way that we want it to be reacting better. But the problem is that you can't really, code all of that out. It's inherent and it's in there. It's a part of that system. And so that's why we need some of these safeguards in place. There's a common issue in AI referred to as the black box problem. And that's referring to the sort of opaqueness, the sort of shield that is around AI, because you can't really, crack it open and see well, where did you go wrong, right? It doesn't work that way. And so if a person gets rejected for healthcare or a person's treatment is rejected, you might ask well, why did I get rejected for that? And it's very difficult to go back into the system and find the pinpoint out. And so again, my concern is with some of this data being inherent in it is that there are going to be some of those rejections that occur, and we're not really going to be able to determine, why that happened, find that sort of evidentiary link as to why it happened. And look, I'm an attorney, any attorney worth their salt who's working for these large tech companies, they're not going to admit oh yeah, there's historical biases in here. That's why this acted that way. They're not going to do that. And absent any of this regulation to kind of, make them comply with Pennsylvania values, American values, they'll come up with sort of all sorts of loopholes as to why they shouldn't be.
And there is, I'll answer this question from a HIMSS point of view. So over the years, HIMSS has developed some technology best practices that you could aspire to and actually should be able to achieve over time. HIMSS has what's called its 7 levels of organizational and technology maturity. And this is a very deliberate approach to understanding, assessing, and attaining your measurable maturity within an environment that demands discipline and it requires accuracy of your data. And when we talk about sloppy data, for example, and let's use that term for a moment, less than optimal outcomes do not necessarily come from bad data per se or sloppy data per se, but the sloppiness in that may be we've got incomplete data or we're misapplying data, especially from an informatics point of view. The point of the 7 levels of maturity of HIMSS and how it's applied is to make no presumptions or assumptions about your organization. Look at these 7 levels of maturity guidelines and assess, is your organization mature enough? Are you technically capable enough? Do you understand what's going on with the data? Do you understand that you may be missing data? Do you understand that data might be being misapplied? Are you really organized and on point enough to use your data interoperably so it maintains the consistency and integrity of your data throughout the process? So when you're giving the doctor the information that he needs in hand at point of care at the exact time that he needs it, you're giving that doctor the best data that he could get, be it through a data sheet or through a report that comes out of AI. So you can look into, you can Google this through HIMSS and look up the 7 levels of maturity, because it does get quite deep. But there are mechanisms that are in place across the industry, like the 7 levels of maturity from HIMSS, that allows your organization to go through a process, a certification process, to understand that when they've reached level 6 and more importantly probably level 7, especially when we're dealing with AI. Now you're capable, you're mature, you've got the discipline, you've got the structure to understand what it's like to mitigate sloppy data, to make sure that you've got the data that you need. The data is not incomplete, to make sure that your data is organized and applied as it needs in terms of patient care. So there are mechanisms in place that will help us that already feed right into the issues that we're talking about for being readied and prepared for AI.
Thank you. You have a follow-up?
Thank
I'm
you.
sorry.
No, I just wanted to say thank you. That was a very helpful answer. Thank you so much.
I know we have one more question. I'd ask just to be brief because we're running over like 15 minutes and we have a lot of people. So Representative Rivera.
I'll be very brief. I just a few takeaways from what I heard from you. I'm very glad you're here to support this. One of the things I never want to hear from my own physician is, I Googled your condition and this is what they told me. So guidelines around any tool that's put into human hands is something that I'm willing and desire to talk about. So as you said, outsourcing services, Mr. Branch, you said outsourcing services to a robot, certain things can happen, but that diagnosis I would want from a human, even if there's some bias, because I'd rather talk to a human about the bias than, like you said, try to figure out where the sloppy data came in and why there isn't an explanation and why we can't talk about that explanation. So I do appreciate all of the new tools that come into our realm that we can use for good and help us learn how to not use them for bad. And I do appreciate hearing your testimony today. So thank you.
Thank you very much. We appreciate your testimony. Our next panel is our state government panel. We have our Commissioner of Pennsylvania Insurance Department, Michael Humphreys, Esther Blair, the Senior Deputy Attorney General of the Attorney General's Office, and Elizabeth Oquendo. Am I say that right? All right. Well, you could correct me because my name's said wrong all the time, so I'm used to it. Senior Deputy Attorney for the Pennsylvania Attorney's Office. We've also been joined by Representative Day and Ledbetter. So however you guys want to go.
Good afternoon, Chairman and members of the committee. I want to thank you for inviting the department to offer remarks on House Bill 1925. My comments will focus on the use and regulation of AI in the commercial health insurance industry, and I'll try to be brief in summarizing my written statement. The insurance industry is constantly changing to adapt to technology advances like AI and to incorporate them into their business practices. While the department lauds technological advances, we expect insurers to incorporate these advancements responsibly. As you may know, I chair the National Association of Insurance Commissioners Big Data and AI Working Group. I'd like to highlight some of the recent activities of that group before returning to the proposed legislation. In 2023, the NAIC adopted a model bulletin on insurers' use of AI after extensive engagement with stakeholders, and that includes consumer representatives, provider representatives, insurance industry, and others. Pennsylvania adopted a Pennsylvaniaized version of that bulletin in April of 2024, and as of the end of October, I think 25 states have adopted it in some form, although I saw in the clips that Hawaii adopted something last week. I haven't confirmed how closely it tracks to that bulletin. Our bulletin was intended to ensure that insurers are aware of the regulators' expectations on how AI systems should be governed and managed, and to confirm that existing insurance laws and regulations apply to insurers' use of AI. The bulletin included recommended best practices for how long insurers obtain, develop, and use certain AI technologies and systems, and advises insurers on how to make informed decisions on the use of AI. The working group has also been examining how insurers currently use AI and has been producing public reports over the last several years. We started on the homeowner side, moved into auto insurance, life insurance, and earlier this year, we released a 226-page report on health insurers' use of AI. And while I can make that available, I'll just highlight a couple key points from that report here. 92% of the companies that completed the surveying, so that's 86 out of 93 companies, indicated that they currently use, plan to use, or plan to explore using AI or machine learning in their business operations. Only 7 of the companies said that they have no plans to explore or use AI. Health insurers indicated the most common use of AI in ML is in strategic operations, utilization, severity, quality management, fraud detection, sales, and marketing. After issuing that report, I announced a request for information. And really, we did that asking stakeholders whether the NAIC should produce a model law to help move the national discussion forward. Feedback was mixed, as we heard from, again, dozens of interested parties. And I would say at our summer meeting, the conversation pivoted to the use of AI in prior authorization and utilization review space. Representatives of America's Health Insurance Plans and Blue Cross Blue Shield Association, the 2 largest health insurer trade groups, discussed a recent announcement from earlier this year where their members committed to streamlining prior authorization processes to improve patient care and remove administrative burdens. I specifically asked them about having a human in the loop, and the Blue Cross representative said that its member companies affirmed that requests not recommended for approval based on clinical reasons will continue to be reviewed by medical professionals before being denied. In examining the existing legal standards in Pennsylvania, I'd like to take the opportunity to highlight Pennsylvania's bipartisan Act 146 of 2022, which we interpret to say that insurers may not deny prior authorization requests without involving a human being in the review process. This existing interpretation and the commitment from insurers is consistent with the provisions in the legislation. Further, in HB 1925, the department believes that several of its provisions could be beneficial. We appreciate the requirement that insurers shall disclose to both providers and insureds if they are using or will use AI-based algorithms in the utilization review process. We also appreciate the reporting requirements, that as many are pretty consistent with what's already in our model bulletin and was issued here. The requirement to report to the department a summary of the function and scope of AI-based algorithms used in UR will provide PID with a clearer understanding of how insurers are using this technology. And those provisions are very similar to what we're calling a systems evaluation tool that the NAIC working group is currently in development of. This tool, it's a series of exhibits that state regulators could use to better understand and evaluate an insurer's use of AI and to identify risks within the companies. So at last week's NAIC Fall National Meeting, my working group spent 4 hours working through the second version of this tool, which is somewhere around 10 pages across the 4 exhibits. Our goal is to complete it, obviously we're running out of time for later this year, early next year, so states can start to pilot it at their insurance departments to work with companies to see where gaps may lie, where we may want to revise this tool. Pennsylvania was on the drafting group that came up with the tool, and my financial team has already started to implement parts of the tool. When we go out for financial exams, as you may know, every domestic company to Pennsylvania gets an exam every 5 years. We're starting with some of the questions that we've already put into this tool and have had companies working with us to build those answers and build that understanding. HB 1925 includes one provision that would have contractors and vendors of an insurer be subject to the requirements of the bill. We would respectfully suggest that the provision is misplaced in a law directed towards insurers, but we would welcome a discussion on how to appropriately regulate third parties. The department does not regulate entities that supply AI algorithms or services, just as we don't regulate a myriad of other entities that contract with insurers, but again, would be interested and certainly willing to engage you on that discussion. So in addition to modifying that provision, the department would suggest a few other technical edits that are in the written testimony. So again, we appreciate your introduction of HB 1925 and the opportunity to engage on the insurer's use of AI. Appreciate the opportunity to be here and look forward to any questions.
Thank you.
Good afternoon, members of the House Communications and Technology Committee. Thank you, Chairman Cerisi and Chairman Ortitai and Representative Venkat and the committee members for inviting us to speak today. My name is Esther Blair. I'm a Senior Deputy Attorney General in the Healthcare Section of the Pennsylvania Office of Attorney General. I'm joined by Elizabeth Okendo, who's also a Senior Deputy Attorney General with the section. I'm going to provide our testimony, but we're both going to be available for any questions. We appreciate the opportunity to provide testimony on House Bill 1925. The mission of the Office of Attorney General's Healthcare Section is to safeguard the rights of all Pennsylvanians to receive fair, equal, and adequate health care. We advocate on behalf of Pennsylvania consumers who have issues with healthcare providers, pharmacies, insurers, and medical equipment manufacturers, and we work to protect the rights of Pennsylvania healthcare consumers under HIPAA and state breach notification laws. Attorney General David Sunday has made healthcare accessibility a top priority of his administration. In the face of potential federal bans on state regulation of AI, General Sunday has recently led bipartisan coalitions of attorneys general to ensure that states have the ability to manage the growing role that artificial intelligence plays in our lives through legislation and regulation. General Sunday believes that with an issue as complicated and fast-moving as AI, that the states play an essential role in protecting those we serve from some of the dangers of this powerful new tool at our disposal in healthcare and in many other sectors. Artificial intelligence offers tools to healthcare providers, health insurers, and managed care plans that improve access and outcomes for patients. However, the Office of Attorney General recognizes that there is potential for these AI tools to lead to adverse patient outcomes or to limit healthcare access for certain groups. We believe that this bill establishes needed guardrails to guide the use of AI while protecting healthcare consumers and allowing for the innovation and efficiency that AI tools can provide. We support the bill's plan to regulate the potential of AI tools to create erroneous information through hallucination or other mechanisms, or to make recommendations that result in bias or discrimination among patients. We agree that any recommendations made by AI tools should be reviewed by a competent human to provide an important check on machine-based decisions. House Bill 1925 could be strengthened by adding some additional provisions that center on coordination of regulatory rulemaking, ensuring consumer privacy rights are protected, and recognizing the Office of Attorney General's enforcement authority to protect consumers. First, regulations or guidance promulgated by the Department of Health, Insurance, or Human Services should have some congruence. While we recognize that these three departments have jurisdiction and specialized knowledge as relates to the entities that they regulate, collaboration among these three departments in developing and promulgating regulations would be beneficial so that there is uniformity and consistency in the understanding of requirements for the use of AI for healthcare entities, consumers, and state agencies. Second, regulations should also address the need to protect the privacy of healthcare data, should limit the use of data collected to the intended purpose, and should ensure that AI tools have adequate safeguards in place to assure the confidentiality and integrity of healthcare data. Regulations should also address the need to provide transparency to healthcare consumers about when AI is being used as a factor in their care and in insurance coverage decisions. Third, House Bill 1925 currently provides for oversight and enforcement through reporting, attestations, and the imposition of corrective action plans and penalties by the three regulatory agencies. The Office of Attorney General suggests that House Bill 1925 could be strengthened by including enforcement authority for the Office of Attorney General in its capacity as the consumer protection advocate for Pennsylvania's healthcare consumers. The Office of Attorney General has the power to seek civil penalties and injunctive relief on behalf of impacted consumers through our unfair trade practices and consumer protection law. We suggest that explicit recognition of this enforcement power in House Bill 1925, making violations that violate the bill per se violations of the consumer protection law, could bolster the enforcement power delegated to the 3 regulatory agencies. We envision legislative authority for the Office of Attorney General to serve as a parallel enforcement mechanism to obtain relief for individual consumers who have been harmed by the use of AI in violation of this legislation. As noted previously, the healthcare section of the Office of Attorney General enforces the HIPAA high-tech regulations, the Pennsylvania Breach of Personal Information Notification Act, and the Consumer Protection Law. We have expertise and experience in representing the needs of healthcare consumers and protecting their rights. We would welcome the opportunity to work with the Departments of Health, Insurance, and Human Services in the development of regulations and guidance and in bringing enforcement actions when necessary to resolve violations of AI guardrails. We appreciate the opportunity to share our thoughts and are grateful to Representative Venkat, his team, and this committee for the thoughtful and collaborative approach that has been taken to ensure that Pennsylvania healthcare consumers have necessary protections in place when AI is used in providing health care or making coverage determinations. The Office of Attorney General recognizes that additional legislation is needed to support transparency, human decision-making, and accountability in AI, in addition to existing laws on safety, privacy, and bias, and supports House Bill 1925's approach to regulation, which balances the benefits of AI with the need to protect all Pennsylvanians.
Anything you want to share, or?
I'm just here to help answer questions. Thank you.
Thank you all very much. Representative Venkat has a question, but I said it's his bill. He's going to wait a second for my question.
Thank you so much, Chair Cerisi. My question is for Commissioner Humphreys. Thank you so much for your testimony. You mentioned the model bulletin that is there in place in Pennsylvania now. My question related to the insurance department is, the bulletin is out there. Is there any reporting requirements or other way that either the public or the department can look at whether insurance companies are complying with the bulletin in the context of their use of AI?
There's not a written disclosure to us or reporting standard per se. I think that's part of what some of those next steps that, at least at the national level, we'll be looking at as part of the evaluation tool. And I know it's included in the legislation too, is kind of where I think it aligns with what we're doing at the national level is kind of the development of what information would be helpful for people to understand about what the company is doing. And that's something that I've kind of continued to ask interested stakeholders at our NAIC hearings, is kind of including particularly really the consumer groups, or when and how do you feel like you need to be made aware? So yeah, we're working through that.
Okay. The second part of the question is in your written testimony, you mentioned the potential for model legislation and that there's been pushback at the NAIC model legislation level from, it looked like, from insurance stakeholders. And so in that context, and you may be opining as opposed to giving a definitive answer, what is the likelihood that we will see either model legislation or federal standards related to transparency, human decision-making, and protections on privacy, safety, and transparency, and anti-discrimination? Or are we left with state legislative action being the pathway that we can affect those requirements given the difficulties at the federal or in model legislation level?
Yeah, that's a great question. And that's really what the bulk of our August meeting was, kind of having robust conversation. And to your point, the stakeholders that tended to say, we're not at a point where we need model legislation, at least yet, and to their credit, it was yet. was the insurance industry. Their position was that the states have existing authority, that existing laws and regulations apply to insurers' use of AI, which is true, and is the purpose of the bulletin itself, was to clarify the application of our existing tools to new developments within the insurance companies. Those that tended to favor additional legislation, I think, were the consumer groups, provider groups, and I think the membership was split because I think everybody recognized the importance of protecting consumers. The question was really kind of when. Do we know where the gaps are already today such that we feel like we should be drafting legislation right now, or will these next stages, like the development of the evaluation tool in states piloting that tool over the next year or so, help us define what legislation looked like? So I think even stemming from that discussion, there was a subset of discussion that was really focused on just I would say just almost a consumer bill of rights piece. That would be a limited subset, because when I initially issued the request for information, it was really broad. It was, we should look at corporate governance, we should look at disclosure, transparency, how companies are allowed to use it, the protection of consumer data as part of that process. I think during the conversation, it really focused, and I think part of this and how it plays out is kind of the national conversation has also focused on prior authorization and utilization review. So I think if we were to kind of bifurcate the discussion at the national level, I think first we would see potential development of a model legislation that focused on when and who needs to be informed of the use of AI and how to do it, whether it's a statement on the website, in general terms, followed up by more specific disclosures to consumers and providers like what's provided in this legislation, or if there's additional paths to pursue. I would say that's still up in the air because there are a number of my colleagues that think we should kind of see the process out before we start drafting the legislation. I think that the complicating factor of all of it, and it's one that I had brought up through the conversations, is that sometimes in the insurance space, in the absence of NAIC model legislation or more uniformity across the states, you see Congress get more interested in either setting a ceiling or a floor around what states are able to do. I think you saw that in the passage of H.R. 1 earlier this year, where initial versions of the bill included a ban on state AI laws that would be upwards of 10 years plus. I think state legislators, including a number of Pennsylvania legislators, signed on to letters urging Congress not to go down that path. I know the NCSL did the same and put out policy statements along that same vein, and ultimately it was pulled out of that bill. There was an executive order, though, issued at the end of last week in a similar vein with similar themes, so that's something that we're looking at kind of as the conversation progresses both here and nationally.
Thank you. I have two quick questions. Commissioner, one thing you said is 92% reporting companies indicated they use AI and plan to use AI. What about the other 8%? Why aren't they, and what type of companies are they?
They were all health insurance companies. So that number of 92 or 93 companies that were surveyed, they're all larger health insurance companies across the state. So a number of Pennsylvania companies participated, and then you have Blues plans and other plans in other states and the national companies. So those that tended to say no, and I know this was a survey done last year. I think just the initial feedback was we don't know enough yet, or maybe it was smaller regional companies that don't have the resources of some of the larger companies and wanted to see it kind of play itself out a little bit further before they get too far down that path.
So it wasn't a no because we don't believe in this. It was a no because they don't know enough about it yet.
As far as I know, it was not a no, we don't believe in AI.
Okay. And the question for the Attorney General's office is, what type of complaints have you seen already regarding this in the insurance industry from people who have had health care issues that's coming to the Attorney General's office?
So most of our complaints are about denial of coverage that we've seen, where consumers are concerned that AI is being used in utilization review denials. unfairly, usually, when we're receiving a complaint.
And how do you determine whether they're right or wrong? I mean, the insurer could say, no, we're not doing that. How do we know they're not?
So generally, when we receive a complaint, it goes through a mediation process. So we have agents, our agent supervisors here, who act to try and resolve the issue between the consumer and the provider. If we have a number of complaints involving a same provider that are not being resolved, then it gets kicked up to us with the attorneys, and we will do a full investigation and then take action if needed under our consumer protection law.
But I think just to add to that, so when we do have a consumer that says, hey, I'm concerned that my procedure was declined, right, by the insurance company, and I'm concerned they're using AI, I think that highlights a key issue that's addressed by this bill, right, which is the transparency that consumers need to really understand, A, when AI or if AI is being used, and B, how it's being used. It's tough for us as the AG's office to answer that question for them. We go back and forth through our agents and do a mediation session. They escalate the complaint as high as they need to try to get answers as to what factors were considered in making the coverage decision. But that's just one consumer that had our 1-800 number and was able to get to our office, for example. I think that there are going to be lots of consumers across the Commonwealth that have these questions. And, I think this bill does a great job of that first step of putting that information out there so that consumers even know what to ask, how to ask, and who they can ask.
Yeah, Chairman, if I might jump in
Yes,
on
go
that as well. As I mentioned, under Act 146, they shouldn't be using an AI system to deny a claim. And I think where you see it most often when it's used in the claim space is to, in an effort to speed the process, it gets to yes faster, right? But it also gets to this is the gray area faster. And when you get to that gray area, that's when the human has to come in to ultimately make that potential adverse decision making against the coverage.
Thank you. Anyone, Gary Day has a question?
Thank you, Mr. Chair, and thank you to my colleague for tackling such a large issue and bringing people together to discuss this. I noticed that in enforcement and oversight, the bill has that function among different agencies, and I would hope that that would be an overlap and probably coming at it from each of the agencies' viewpoints on this matter. But I was just curious, if it has differences, will that be confusing for enforcement to the end user? We always want enforcement to be a teaching and educational as well, so that people will then get with the program, let's say, and do it correctly. So do you guys recommend that be changed at all with the legislation that you've reviewed today?
I mean, we're happy to join. We expressed the same concern in our written testimony. We would like to see some, at least, agreement amongst the 3 state agencies to decide things like common definitions, common terms, so that when the consumer is looking at this, we're talking about the same issues and the same data points kind of in the same way. And then, making sure that they are talking also about, the different regulatory enforcement mechanisms that they're going to use, make sure there's some kind of congruence there as well. So we would recommend them either working together or, at least having some communication about that before the regulations are promulgated.
And that would be on the regulations that each agency puts out on this, is that correct?
That's right.
Coordination to make it easier to be able to follow and then enforce. So I appreciate that. I was concerned about that and just curious what you thought. I think it's just make a quick statement here just to add to this and try to help get this across the goal line. When a clinical decision is made, I've always viewed it's the insurer's function to double check that clinical decision. And we have an opportunity here with AI that we actually strengthen this function between insurers and providers. And, if AI would be used to crawl over everything that's happening in the public domain or everywhere in clinicians throughout the world and how they're addressing certain decisions, and could instantaneously bring that information back, it would almost seem to me that AI might be better than the current knowledge right then, because it's and that might be a positive function of AI coming forward. Also, I think the crux is that a lot of us are looking at this like, and I think our prime sponsor looks at this as the clinician wants to be able to talk to a human being and not just argue against a machine or argue, and I think if we put it in the process where the clinician puts in and then the decision I would say could be rendered by AI, but an appeal to bring that human person into the appeal process, that might be the best way to keep using the positives of AI while also not by mistake injuring a patient. I trust that clinician at the front end. We have many of them here with us today, and my daughter's in that line as well. So thank you for being here today, and Mr. Chairman, thank you for allowing the questions.
Thank you. Anyone else before we move on? Thank you all very much.
Thank you.
Our next panel is our panel for hospitals and healthcare systems. We have Jess Boyle, who is the Senior Director of Digital Transformation at Children's Hospital of Philadelphia. Dr. David Varga, MD, Chief Medical Officer of WellSpan Medical Group, Senior Vice President of WellSpan Health, and Hunter Young, who I think is on virtually, right? Yep. Head of State Government Relations at ATA Action. So why don't we start with the virtual and then work our way backwards? You guys are okay with that? And we're joined by Representative Waxman. So Hunter, why don't you begin for us?
All right, can everyone hear me okay?
Yes.
All right, thank you. Good afternoon, everyone. My name is Hunter Young, and I serve as the Head of State Government Relations for ATA Action, which is the American Telemedicine Association's affiliated advocacy organization. We are focused on advancing policy to ensure all individuals have permanent access to telehealth services across the care continuum and support the enactment of state and federal telehealth policies to secure telehealth access for all Americans, including those in rural and underserved communities. Between ATA Action and our larger ATA membership as a whole, we have a very broad membership, which includes telehealth providers, healthcare systems, payers, digital therapeutics, and many other stakeholders across the healthcare and digital care industry. First and foremost, I want to thank Chair Cersei, the entire Communications and Technology Committee as a whole, and staff, as well as Representative Venkat, for your willingness to consider our feedback and consider feedback throughout this process. I also want to take this opportunity to reiterate our support for the intent of this legislation. Our organization has been following state AI policy across the country, and we believe that the introduced version of this bill represents a very strong starting point, especially relative to what we've seen in some other states. However, we believe that the legislation could be even more effective and avoid unintended consequences through some carefully considered amendments, which we went into details on in our submitted written testimony. In an effort to not rehash all of those, I'm just going to touch on a couple areas of our greatest concern at a high level now. So first, the bill contemplates significant compliance requirements for healthcare entities and substantial annual reporting and documentation to the requirements to the Department of Health. We have significant concerns regarding the burden these mandates could impose, particularly on smaller entities serving small client populations, such as patients receiving treatment for opioid use disorder or mental health. These companies often have small compliance teams and could opt out of using innovative and beneficial AI systems in the healthcare setting to the detriment of patients in order to avoid expensive and onerous compliance regimes created by an annual reporting requirement. While we agree that health entities developing and employing AI for clinical decision-making should have compliance mechanisms in place, we suggest an attestation or a certification when such systems are in place instead of the annual reporting requirement. Second, and relatedly, the magnitude of the compliance burden contemplated under this act is directly tied to under which AI use cases it is triggered. For that reason, we urge this committee to focus and be precise on the circumstances for the specific tasks when the department would want documentation if AI is used. Without such clarity, broad terms such as without such clarity in broad terms like clinical decision-making, a single facility could be subject to substantial reporting requirements for use of multiple AI systems. Third, ATA action suggests reconsidering how regulated AI applications developed or deployed by third-party vendors partnering or contracting with health facilities. We agree that AI systems should meet the same standards as if they were developed by the healthcare facility, as if they're being used by the facility. However, rather than expanding new regulations and regulatory authority over technology vendors, we encourage the committee to instead make vendor compliance part of the partnering facility's compliance reporting. And finally, and this is a big issue for our membership, as currently drafted, this legislation does not take into account FDA-cleared products, instead treating all products the same, which we believe is potentially harmful to patient care in the long run. FDA-regulated and cleared digital therapeutics and AI tools are held to rigorous standards, including quality management systems, cybersecurity requirements, and mandatory adverse event reporting, ensuring both safety and efficacy. These products undergo clinical validation, are subject to pre- and post-market oversight, and involve regulated healthcare practitioners as gatekeepers protecting patients throughout the care process. We think it's very important to maintain the distinction between these regulated products and unregulated products, as it is essential to protect patients while allowing safe, evidence-based digital interventions to thrive. We ask that as the committee considers this legislation, exempting AI systems that have already been cleared by the Food and Drug Administration at the federal level. Thank you again for the opportunity to weigh in and testify, and myself and our organization look forward to continuing to work with the sponsor and the committee to advance digital health policy in the Commonwealth. Thank you.
Thank you very much. Yes?
Chair Cerisi, Chair Ortatai, members of the House Communications and Technology Committee. Thank you for the opportunity today to testify on House Bill 1925. My name is Jess Boyle. I'm the Senior Director of Digital Care Transformation at Children's Hospital Philadelphia. On behalf of CHOPS, Clinical Informatics and Compliance Leadership, we appreciate Representative Venkat's leadership and this bill's goals of patient protection, transparency, and responsible innovation in AI. My testimony today outlines recommendations that are intended to align with the bill with the operational realities of our health systems, as well as maintaining strong safeguards for our patients. First, we recommend refining the definition of artificial intelligence. Given this is a fast-moving field with new foundation models and techniques ever emerging, we recommend defining AI by a category of its use within healthcare specifically, rather than by the technical implementation of algorithms or data inputs or outputs. By focusing on the categories of use specific to healthcare, the legislation can clarify which low-risk activities are exempt from oversight and which high-risk activities should be the focus. A functional definition, such as clinical decision support, administrative automation, communication aids, risk prediction, radiology or pathology image analysis, will ensure that the statute remains technology neutral and future-proof. We recommend excluding validated and long-standing technologies, such as something like an automated external defibrillator. This is an algorithmic artificial intelligence device to some degree, or electrocardiogram, EKG devices that provide an interpretation, something that is happening every day throughout the Commonwealth. Rule-based algorithms such as decision support logic in the EHR, which has been happening for years, well validated, as well as low-risk tools such as medical calculators or AI-enabled reference materials or search tools, which are used by clinicians daily, from these statutory requirements. Second, we recommend clarifying institutional responsibility. Health systems cannot assume liability for the technical provenance, model training, or the fine-tuning of third-party AI products. This is both technically infeasible and contractually prohibited. A health system would not, for example, have access to the training or performance data of a commercial AI algorithm, nor would a vendor disclose those details as they represent the intellectual property and competitive advantage of that product. We suggest clarifying that facilities are responsible for establishing internal review and robust governance processes, but not for validating the source code, the model weights, or the data sets that might be owned in this particular case by vendors. Third, we recommend emphasizing governance and oversight rather than technical attestation. We support the intent to require accountable oversight, but recommend focusing on compliance obligations on process-based enterprise governance. For example, attesting that a health system maintains a multidisciplinary AI committee, analog to a hospital's therapeutic standards committee or a quality assurance committee, which are all throughout the hospitals of the Commonwealth, to oversee AI use. This approach ensures safety and fairness without imposing unattainable technical certification requirements. Fourth, we recommend calibrating disclosure obligations. CHOP supports transparency when AI is used in patient-facing applications. We suggest distinguishing between legally required disclosures, such as when a patient voice or image data are recorded or used for secondary purposes, and recommended transparency disclosures for clinician-reviewed tools. These tiered approach balances patient awareness with operational feasibility. We support the exclusion of disclosure for low-risk use cases, such as draft communications that are reviewed by a human before they're being sent, AI chart summarization features, once again, reviewed by a clinician in detail, as well as AI-powered workflow aids meant to empower clinicians. These exclusions can be and should be enumerated in Section 3501. Finally, CHOP recommends including language focusing on the need for sound compliance processes. For example, a facility shall establish policies and procedures for implementing, using, and monitoring artificial intelligence and a governance structure to maintain responsible use of that artificial intelligence and those based algorithms within the facility prior to its use, during its use, and then on a continuous basis evaluating its use. CHOP applauds your proactive attention to the emerging governance of AI in healthcare, and we would welcome continued dialogue as this bill, 1925, evolves. And I just want to thank you all for your leadership, for the opportunity to share my perspective, and please feel free to contact me if we can ever be of assistance. Thank you.
Thank you. Dr. Verga?
Thank you, thank you, Chairman Cerisi, and thank you, Chairman Cerisi and Chairman Ortitai, and the members of the House Committee, the Communications and Technology Committee. I very much appreciate the opportunity to provide you with testimony today on House Bill 1925. My name is Dr. David Vega. I'm Senior Vice President and Chief Medical Officer with WellSpan Health. Every day, our 23,000 team members live our vision to be a trusted partner, to reimagine healthcare, and to inspire health. We think high-quality healthcare should be simple, personal, affordable, and accessible for everyone. So at WellSpan, we're strategically deploying AI to solve some of the most pressing challenges in healthcare: workforce shortages, clinician burnout, and the growing complexity of patient needs. The marriage of human expertise with technology like AI is improving patient care and outcomes in ways that were unimaginable just a few years ago. For example, our AI-powered diagnostics for radiology analyzed over 200,000 imaging studies last year, identifying more than 10,000 potentially critical findings, including pulmonary embolisms, brain hemorrhages, and strokes. Over 96% of these alerts reached radiologists in under 3 minutes, accelerating life-saving interventions and eliminating more than 900 hours of unnecessary delays. These are not abstract numbers. They represent real lives saved and families kept whole. The very core of hospitals and health systems' missions is to serve our communities. Financial pressures and workforce shortages jeopardize that mission. For example, Pennsylvania faces an estimated shortage of 20,000 nurses. This workforce gap demands innovative solutions. And AI is helping us reclaim some of our human capacity. This year, WellSpan is on track to recover 400,000 hours of team member time that can be redirected from administrative tasks to direct patient care. At WellSpan, this is not about replacing people. It is about empowering them to do what they do best. And our ambient listening technology turns patient-provider communications into clinical notes, reducing administrative burden on providers, allowing them to see additional patients each day, and improving patient interactions. Anna,
Our AI-powered clinical assistant has handled more than 2 million conversations in multiple languages. Our patients' experiences have improved as hold times and dropped calls have been reduced dramatically. As this committee and the legislature consider House Bill 1925, we'd like to thank the committee and Dr. Venkat for his work on the legislation and his willingness to hear and implement feedback from stakeholders. I'd like to address a few key areas of the legislation. First, disclosure and trust are paramount. That's why every AI solution that we deploy is secure, clinically validated, and transparent. Second, technology adds tremendous value, but it can never replace empathy, expertise, and judgment. That's why we ensure a human is in control in any clinical use of AI, and every solution we design is human-centered and co-designed with our frontline teams and patients. AI also helps us reach underserved communities and patients. Many have experienced a lack of access to healthcare because of a language barrier. Our multilingual AI care assistant can help close these gaps, such as how it allowed us to connect more effectively with our Spanish-speaking population about colon cancer screening, resulting in more at-home screening tests being requested by patients than we were able to achieve with other outreaches. Regulations governing AI in healthcare must remain adaptable to keep pace with rapid innovation. Flexibility is essential to ensure that hospitals and clinicians can safely leverage these technologies for the benefit of. Risk should be viewed on a continuum, with oversight calibrated to the level of impact and the complexity of each individual application. A one-size-fits-all regulatory approach could stifle innovation and fail to address the unique safety and privacy challenges in healthcare. Tailored, risk-based frameworks are key to fostering progress while also protecting patients. Organizations leading healthcare's future won't be those with the most advanced technology alone. It will be those that align people, process, and technology to deliver compassionate, personalized care. And at WellSpan, that is our commitment. So thank you again for the opportunity to present remarks on behalf of WellSpan Health. I'm happy to answer any questions that you might have this time.
Thank you. I have a quick question before I get to anyone else. And I was just sitting here thinking about this, and of course, we're all too young in this room to be able to answer this question, but when X-rays first came out, when all this new, that was a new technology. I mean, when we look at, you brought up about cardiograms and when you go, you know, for the heart screenings and all new technology, how is it really different than AI? I know AI comes up with a summary, but what's the difference? Like, when that all happened, people had to go, oh, was this real? Are we really, is this better than the doctor? Can they really tell in this? Is this going to screw things up? I mean, from your training as a doctor and in the medical industry, what do you see as the differences in educating people on this?
I think, well, there's every time that we've introduced new technology, there's always going to be questions about how safe it is. And we actually have to ensure that we as healthcare professionals are ensuring the safety above all other things. I'd like to jump, though, to a different technology for comparison rather than X-rays. And Dr. Venkat, you probably know this well. I'm an emergency physician as well in clinical practice for over 20 years. With the electronic medical record, it offered some really great advances in being able to have access to depth of data and information that we didn't have before. It gives patients great access to real-time information about their own healthcare. Wonderful thing, wonderful advancement for healthcare. However, it also turned many of our physicians and nurses into, to some extent, data entry clerks. It actually turned our attention away from the patients that are in front of us and towards a computer screen. What I see as a successful implementation of AI and what the promise is here with AI that's different than past technologies is that it has the promise to help us turn our focus back to patients, to get us to stop looking at computer screens and keyboards as much and instead spend our time talking to patients. If we are successful in the implementation of AI, we will actually restore more of the humanity to medicine.
I think one big differentiating factor in the way that you've articulated this is I think the technology from the past feels a bit more confined and a bit more finite, right? Some of these algorithmic models from the past, like I said, an automated external defibrillator, it's an algorithmic model that says, are these two potential heart rhythms present? If so, then it recommends you deliver a shock, right? Feels like a very finite amount of information. Same thing with EKGs, right? There's a very finite amount of EKGs that are possible, and then that particular machine is trained on that very finite nature. I think with AI, and I think the big thing that concerns some folks is that it is still finite, but the amount of data, because of how we conceptualize data, almost feels to the boundaries of infinite, right? If we're talking about considering, 78 million electronic medical records, that's just a made-up number as an example, right? That feels like an incredible amount of data, right? That no human could ever personally conceptualize. The same thing about, we're talking about these massive data sets in pediatrics that may steer children to the ability to get their unique or complex medical condition diagnosed and treated much faster. Again, we're talking about millions, if not billions, of medical records. And I think that's the big thing for us and policymakers like yourselves, right? Us in healthcare, is that I think the technology of the past felt a bit more finite, a bit more where it's within this kind of like box of control. And now AI definitely feels a little more boundless. And again, I wouldn't say that's necessarily the actual case, but I think that's just our perception, right? I think one of the important things to consider about AI, though, is that, and what I'm very excited about, is that the human by itself, right, we are all fallible, right? We have our challenges. There's only so much that we could perceive. There's only so much we can understand. And that's based on good sleep and adequate caffeine and other factors, right? But you imagine a clinician that's been working for 14 hours. You imagine the stress response of our human physiology. Could AI then supercharge the human to be even more than that human can be, where humans will always remain that level of fallibility, but will AI give us that additional kind of insight, to my colleague's point, to be then that much better at our clinical work in treating patients? And so that, I think, is now taking that to the next level, where those algorithmic models allowed for that to some degree, and now we're talking about that because of how much data, right, to a degree that is something that we never thought possible.
Thank you. Representative Venkat wants to add some comments to that.
Yeah, so Chair Cerisi, I think your question is very well taken, and I think a fundamental difference, and I'd ask the panelists to comment if they agree, is the black box nature decision-making that comes out of AI. When we talk about a CT scan or an X-ray or an interpretation from an EKG machine, we can reproduce that. We can understand where the gaps are. The reliance on AI in clinical decision-making or in utilization review, take your pick, is some prompt is given, data is analyzed, and output comes out, and we are left with, well, how did they come to that conclusion? What is the accuracy of that conclusion? And I think that is the fundamental difference between AI and technology of the past that I tried to allude to in my opening statement about the autonomous nature along with the black box nature of AI far more approaches clinical decision-making by licensed physicians and other clinicians than in technologies of the past. I don't know if you would agree or not.
Yes, certainly agree. And I think that's, to your point, the challenge for us as healthcare systems in utilizing some of these incredible AI tools that were offered through our electronic health record vendors and other well-validated technologies, is as that data set gets larger and larger and gets more and more complex, to your point, that output may be reassuring, it may be encouraging, it may motivate us to something that is, of a certain additional direction, but to your point, then it may also add additional detail that's hard to perceive, like you said, of where that came from. And I believe, yes, that is one of, I think, the challenges. The larger the data set, then that gets more complex. But also, like I mentioned in my comments, right, the visibility into how the process worked isn't something that we're always offered as a health system with our vendors, right? It's, you have to, in some degree, work with the brain, understanding how that electronic brain is coming to that decision-making, where in other cases, FDA-regulated medical products, et cetera, it's already well-known, well-shared, and well-validated.
I would just reiterate, too, that AI exists on a spectrum, right? So we have the ambient listening applications, which basically listen to a physician-patient conversation and turn it into a note so that a physician doesn't have to type it into a computer. Pretty safe. There's no black box on that side of things. You know exactly what you said and what they said and what's going to show up on paper. Our physicians have described this as life-changing. It is reducing burnout and allowing us in Pennsylvania to retain more physicians in active practice. On the other end is the more complicated, deep uses of AI in clinical decision support. Those should always be augmented by physician or clinical expertise. And absolutely, there needs to be a safe, regulated approach to that. However, if we apply the same kind of regulation all across the spectrum without very clear definitions in the bills and in the regulations that we produce, we will end up potentially putting ourselves in Pennsylvania at a disadvantage compared to other states in terms of the people who are willing to choose and stay within Pennsylvania to practice. We already export, we're one of the biggest exporters of graduating medical students out of Pennsylvania. We put a lot of students through medical school, and the new physicians, at least half, end up in other states. So we have to just be very clear in our regulation that we're not over-regulating and stifling innovation that would otherwise benefit our patients and our providers.
Thank you. Representative Day?
Thank you, Chairman. I'm going to step up here for our chairman. He had to step away, and I appreciate being recognized. Just want to say I was chairman of a committee that was at the center of humanity's last great challenge, and that was COVID-19. And during that time, it was the hospitals and the health systems and the entire industry that came forward and really helped Pennsylvania, the state government, press forward. I'm going to just make a public statement that it would be, my caucus's thoughts that you would use everything we learned there to get out ahead of AI and make sure we take advantages of all the positives and avoid all the negatives by working through legislation like this. So thank you, and thank you for being here and being so thoughtful in this process. Thank you, Mr. Chairman.
Thank you. Representative Irvin?
Thank you, Chairman. Thank you for your testimony today. WellSpan is actually in my district, and I appreciate WellSpan always reaching out, and they're very good at keeping us legislatively up to date on bills that are going through. But I appreciate all the testimony, or all the testimony from all our testifiers here. But one thing that I've heard consistently from all the health care systems and hospitals is the overregulation that we are getting, not only from the state government, but the federal government, and the consistent compliance that needs to be upheld in order to maintain your fundings and Medicare reimbursements, Medicaid reimbursements. And would House Bill 1925 adding additional compliance requirements to these thousands upon thousands of already regulations that you have to comply to overburden a healthcare system even more? And of all the other regulations that you do have to comply to, would you feel that that much of what is in House Bill 1925, that it would already be covered under some of those other burdensome regulations that you already have to deal with? And would this just continue to add to taking resources away from your patient's care, and particularly what would this be for even your rural and more rural and smaller hospitals that are out there that don't have that large staff to continue to keep those compliances updated?
So,
I'm happy to jump in first on this one. So at the American Telemedicine Association, we have members large and small, many of whom operate across all 50 states or across a handful of states. And speaking to the compliance obligations and potential burden, I mean, in an ideal world, we would have a federal framework put out for this, as was discussed earlier. That has yet to be the case. So when we're looking at this on a state-by-state basis, especially for our entities who operate in multiple states, the more different compliance mechanisms there are, and the more states that they operate in, the more difficult and the more expensive it is for them to comply. That being said, the provisions of 1925, we think, especially relative to some of the bills I've seen in other states, are starting in a great place. And we just think that there needs to be a little bit of clarity and a little bit of tweaking to make sure that those unintended consequences, especially for our smaller entities serving more niche populations or those that are, as you mentioned, some other in-person providers in those rural areas, that they are not adversely impacted or have a more difficult time implementing this innovative technology as a tool to help expand patient access to care and improve quality of life for providers. So just want to provide that 50-state perspective as well as something to consider when it comes to entities that may operate in other states and making sure that compliance is not overly onerous or incredibly out of line with what some other states may be doing. But you all are on the cutting edge of this, and we appreciate your work in this space so far.
Thank you.
So I've practiced in the setting of a busy level 1 trauma center at York Hospital, as you know, as well as in some of our, in a community-based, more rural type setting as well. And it doesn't matter where you are. One thing is consistent across healthcare is that there is an enormous amount of administrative burden, both regulatory and from other sources. And any increase in regulation will always detract from the resources that are available to care effectively for patients. Now, we're not against regulation. There needs to be regulation because there unfortunately are bad actors out there that we need to be careful with. What we would want is reasonable regulation that considers, for example, in AI, that spectrum of what AI is, regulate the parts of AI that are having the most risk, trust the FDA when it's saying that there's algorithms that are safe, and reduce as much as possible the burden on health systems while still implementing the regulations that keep us safe.
Yeah, I think back to a mentor I had early in my career who used to tell me that if you keep the patient at the center of everything, it's really hard to be wrong, right? So I think that's ultimately answering your question. I think that, we just want to make sure that all of these processes, all these algorithms, all these tools, all these vendors are truly keeping that patient centricity, right? And we work at CHOP, right? This is about pediatrics, and I have 2 children. They're my world, and I assume that's the same for any parents who come to us with their children. So I think that's ultimately, we're already practicing with a very rigorous evaluation model, with already rigorous AI governance, sharing with patients, when we're considering various tools. We have a family advisory committee, for instance, which is very engaged families, where we just shared with them literally last week about a number of the things that we're pursuing in AI, right? So I think a lot of those things, though, that we're already doing today are in the spirit of the bill. And it's really about, I think, giving patients that ability to be at the center of everything and then continuing to resource us to allow them and to focus on them and to prioritize them as the center of everything. And I think considering some of the other comments we made about how one could kind of shift some of those kind of details, right? Consider certain models and not others, certain things that are well validated that you could technically call AI, but they've already been around 20 years. And even though they're algorithmic, maybe don't necessarily apply here, but with the ability and the flexibility to continue to practice, as we wish to with the patient in the center. I think this is very well situated. But keeping all of that in mind, and again, my other comments earlier, I think those are some just considerations to carry forward. And I also want to answer, you had a question earlier for an earlier panel, I believe, about where is there very unique opportunity for AI in a rural community, right? And I think back, so one of the things that's really fascinating to me is this really impressive pediatric data set that's coming out of some of our electronic health vendors, and that's helping some of these children who have medical complexity get to a very specific provider that may be the very specific person they need to diagnose their condition, manage their condition, and then carry that through to potentially something curative, right? I mean, otherwise, that's just a massive sum of information that any parent would have to search for and look for, right? And there's pediatric allergists. There's also pediatric eosinophilic esophagitis specialists, right? And AI might be able to take, when you are the N of 1 child that has that condition in a rural community, and be able to get that information and bring that information around a set of data that you already have at your fingertips as a parent, right? And then steer you in the direction to say, well, that expert for your child is potentially in Philadelphia. They might be in Pittsburgh. They might be in Cleveland. They might be in Honolulu, right? But that can get you there faster and get a diagnosis faster. And that's what I'm really excited about what AI can do, is that it can take all of this information and make it something meaningful faster than we as our human brains could ever do, and also potentially not have to ask a parent who's already trying to be a parent and potentially a professional, right? And be all the things they are for their family and maybe have other children and potentially a spouse or a partner, not also now have to be a technology expert and a medical expert. Even though, by the way, these parents who are well-informed are incredibly well-informed, right? And we want to treat them obviously the best way we can.
Thank you.
Representative Waxman?
Thank you, Chair and Representative Venkat. This is a really important topic, and I appreciate the bill being brought forward. I'm glad to be a co-sponsor. I just kind of want to say a few things to start. First and foremost, it is absolutely appropriate for the state to regulate ahead of the federal government. I understand that, the same argument that we get on almost any new technology is that we should not regulate it. We should allow for it to be done at the federal level. I just completely reject that. I've had this conversation in other technological other areas involving new technology, and it makes no sense to me, in particular when I don't trust the federal government as far as I can throw the president, which isn't far. That's the first thing. The second thing that I want to say is I think most people in this country, in this Commonwealth, do not believe that we have a very good healthcare system, okay? They do not believe that we are delivering quality care at a fair or decent price, right? And we only have to look, a little bit up and across the border to see a very different kind of health insurance system that is much better trusted by the citizens of the country, okay? And so for me, the guiding principle and guiding question is, what are we doing with AI to lower costs and improve care? Because we have a crisis in both of those things in our society right now. What are we doing to lower costs, improve access, and improve care? The technology is going to be everywhere, right? The technology is going to be in our cereal boxes, okay? That's how persuasive this technology is going to be in just a few short years. And so what I want to know is, how do we use AI not just for a tool for the rich to get richer, right, which is how our health system is set up, but what are we doing to make life better for everyone in the Commonwealth? And that's really the question that I have.
So I'm happy to jump in first on this one. And we at the ATA were very proud of how technology already referencing some of the new technology we were talking about earlier. Telehealth is a great example of that, where 10 years ago, there were a very small subset of patients who had taken a telehealth appointment, and then through COVID, the benefits of telehealth were recognized, and now that has made care not only much more accessible, but much more affordable for many people by reducing things like travel costs and not necessitating, especially in rural areas, potentially a long journey to see their provider, and instead they can do it from the comfort and convenience of their own home. I think AI has a lot of that same potential, particularly on the administrative front, in terms of cutting down the cost when it comes to things like scheduling, patient communications in between appointments. These are things that can reduce administrative costs for providers and can help, therefore, reduce the overall cost of care. AI can also be very effective in providing or in supplementing that healthcare especially through these FDA-cleared digital therapeutic devices. I know mentioned some concern about not trusting the federal government. I just want to emphasize that regarding the FDA-cleared devices, that process began, and the first ones of those were approved under the Biden administration and continue to be approved to this day. So just want to make sure if there are concerns about sort of federal oversight, that wanting to make that distinction for those FDA-cleared devices and their efficacy in this space. Thank you.
I would add, as I mentioned during my original testimony, how we have used it in our digital. So as there we go. As I mentioned in my oral testimony here, We have used AI in a number of different ways in WellSpan to benefit patients, and we're seeing great outcomes already from that. The digital imaging part of the thing I already discussed, hundreds of hours of time saved in more accurately, more quickly diagnosing critical findings on imaging. That's improving the health of populations. When we're doing outreach to underserved populations, like our Spanish-speaking population who has a lower rate of colorectal cancer screening than other populations of patients, and we're making an actual difference in there where patients are requesting that home screening test and getting tested more frequently than they were in the past for colon cancer. That's saving lives of underserved populations using AI. There are several studies out there that you can find that will describe how physicians at the bedside who use AI that helps them do clinical decision-making can actually have better outcomes as judged by other physicians. So in case reviews by other physicians, they get better outcomes using AI. And this is not black box AI. What this is clinical decision-making support that provides evidence at your fingertips, and it's all referenced so you know where it's coming from and how it can be applied. Always still requires human intervention and clinical expertise and judgment with it. But those are just a couple of examples how AI is having a real positive impact on our population.
I can think of 3 cases, I think, that directly address what you're referring to when it comes to kind of the opportunity for AI to make the healthcare system more efficient and to reduce spend, right? The example that I was sharing earlier, right, getting, in our case, the child, the pediatric patient, to the best care at first without having to go through multiple layers of what sometimes may appear to be kind of unnecessary consultants. I think sometimes unnecessary tests that come out of that, right, to get to a definitive answer. And the ability for AI to kind of get to that point of that kind of final need, that final answer, and that kind of final continuum of care faster, I'm particularly excited about, right? Because all those kind of steps on the journey are more expensive, right? All of those things that might be done just because they're, accepted kind of practice for a generalist in a particular area, right? If you get kind of more precise with that, you can then have potentially savings in the care model. That's one. The other that I'm really excited about, so we already implemented something called AI chart summarization, right? So some of the children that we serve at CHOP, as you can imagine, are very complex, right? They already have thousands of pages of medical records. And if you can imagine, right, how is a clinician, if they maybe didn't sleep ever, right, to read thousands of pages of medical records? And I'm sure, I don't, if you've kind of ever dug into your own medical records, but some of the things are purposeful, some are just kind of restating the same thing 3 and 4 times. And so the bonus, I think, of AI there is to do summarization of all of this kind of chart detail to the point where then the human can appreciate things that may otherwise have gone underappreciated because they were on page 734 of 2000, right? And that may actually avoid that clinician from sending the child for another set of tests, for another set of diagnostics, another set of radiology, where that was already done. But if it's not necessarily transparent as such, but AI can bring those things out. We've actually seen about 25% of the clinicians who've used some of these tools have found something new that they wouldn't have otherwise appreciated from just reading the record because of the assistance of AI, right? So again, I can imagine that avoiding unnecessary utilization of the healthcare system is one way for that potential savings. And the other is I think where AI can partner with other well-established digital tools, right? So my team, we also lead our telehealth work, our virtual care work, our remote patient management work, right? If we can then further supercharge what we've already done and documented, and we have clinical and operational outcomes in that space, right? Again, there can be some really significant savings with patient centricity, right? One example is saving readmissions. Readmissions are expensive. ED visits are expensive. We can keep those patients out of the ED and out of being readmitted because we can intercede on their condition early. Again, I think there's some opportunity there for savings.
I appreciate these thoughtful responses to my question. I appreciate the information that was brought forward. To me, one of my big concerns is we are living in a time where we need sort of very radical solutions to some pretty big problems. And I think AI can be transformative and has the possible to really change things in a positive direction. But the fear that I have is that we just keep doing things the same old way, but just better and faster. and with bigger data sets. And that, to me, is not necessarily going to be the outcome that I am looking for as we wrestle with how this technology is going to impact all of us. So I thank you for the response. I appreciate everything that you all brought forward there.
Thank you, Representative Nelson.
Thank you, Mr. Chair. I guess my question kind of builds on both Chairman Irving and prior representatives' concern. How would, in your opinion, because we want to be able to use advanced technology to accelerate care, I think everyone agrees there, but very much senior care, community hospitals, they already suffer from the burden of over-reporting. And so a new division or new reporting requirements could be very concerning to them. And so we want to try to achieve this balance to be able to make sure that we can implement technology, enhance patient care, but not do it in a nefarious way. You know, so as a father of 7, rural area, kids break things, you know, and waiting for hours and hours on end in the emergency room for a radiology result, sometimes it takes forever because, so I can empathize and appreciate the speed and the benefit of that to patients. But would that process, so if I'm understanding each of your technology exemptions, existing technology, FDA, the use, physicians' interaction with AI, medical AI, can you touch on some of the constraints so that sometimes in Harrisburg, the pendulum swings too far and we overcorrect. So how can is it a simple acknowledgement balance, and the Attorney General's office already has the ability to review those cases? How do we achieve a reasonable landing space so that we still have premium medical care and we have some patient protection?
Yeah, I think that's very well said. I think, like I said earlier, right, I think some of these well-established, well-validated, well-understood algorithmic models, right, to Representative Venkat's point, where there is a certain kind of, confined data set where we kind of understand how to reproduce that otherwise, right? Those technically are artificial intelligence. It's an intelligent process or machine learning process being done by something other than a human, right? Those may not necessarily be, I imagine, within the spirit of the bill, right, of regulating this very kind of new and innovative and expanding and ever-growing, right, technological venture enterprise, right? It is wherever it goes, right? So I would say that's one consideration to keep in mind. I think the other is like a hospital like CHOP, where we've already done this for some time. We've already tried to do this with the patient in the center of everything, right? With safety as paramount, with outcomes as paramount, understanding and looking at that data and evaluating on a regular basis. Like, we're very open to share on how we went about this with other hospitals in Pennsylvania. Like, this is not our intellectual property. This is something that we believe is for the care of all the children we serve, but any child who comes to us would, have that same benefit. Doesn't matter where they come from, right? But the same thing, I think, is, we're glad to offer some of our own assistance to say, this is the way that we've done this is the way that can be done for a smaller hospital, for a place that wants to implement tools but may not have the same personnel or the same funds or the same ability to do so, and what we've kind of learned from that, right? So I think that's another area where we just as hospitals and health systems, with you all as regulators can find a way to kind of meet in the middle. The other thing to consider is, where is that true human in the loop, right? Is the human in the loop of the actual acute decision making, or is the human in the loop in some kind of post-evaluation criteria? And then how much opportunity is there to modify that at times, right? If the human is really at that fundamental level of decision, or like my colleague mentioned, right, with these like ambient scribe tools, for instance, right, where it's not making a decision, it's merely shifting the clinical experience back to the patient centricity we've always wanted. I don't think any clinician has ever got into clinical practice to say, you know what, I want to go be a doctor, and then I want to turn my back to you and stare at a computer while I hear all about the things that why you're here today, right? Nobody will want that. No patient wants that. No practitioner wants that. But those kind of models are just merely capturing that in a way then that redirects care back to the patient, right? Those there may be significantly less risk than some of these kind of risk deterioration models or clinical deterioration models, once again, unless there's that human in the loop. So I do think it's nuanced, and I think there's some things to consider. And again, artificial intelligence in the definition is can be very broad. So we've got, like I said, right, maybe honing that in a little bit more specific to kind of what is the current practice of healthcare, and then where are we looking to take this in the future.
I think Mr. Boyle makes a very good point about understanding where there is expertise and judgment from a human in that loop. If it's information being provided by AI to a physician who's processing that and making clinical decision-making off of that, and the information coming in is based off a data set like an electronic medical record or reference data like you'd get in journals, that's pretty low risk. It's the physician that's still making the clinical judgment. Regulation isn't going to get you a lot there. It's just going to add extra burden that will turn our attention away from patients. When there is, the black box type situation where there's anything that resembles AI making a clinical decision on its own, that is where the risk lies and where we need to spend our time.
Thank you, Mr. Chair.
I would very briefly, if I could add, and this is elaborated more in my written comments, but really emphasizing the need for really strict clarity around the clinical decision-making and when things need to be disclosed and when they don't. Specifically right now, under duty to disclose, it says a facility shall disclose to the patients of the facility if AI-based algorithms are will be used for clinical decision-making or similar tasks. That or similar tasks really has the potential to create a lot of confusion and perhaps lend itself to that over-regulation concern because it's so broad, where in our view, things are either clinical decision-making or it's not clinical decision-making. So I think that's sort of an area, as we talk about clarity and definitions, that certainty is going to be needed for entities and providers using AI.
Thank you. Any other questions before we move on? Thank you all very much for being here and your testimony.
Thank you all.
We're going to proceed on. We're running a little bit behind schedule by about 20 minutes. So again, I would ask for the testifiers, please do not read your testimony. If you can summarize it so we can ask you questions. Our next panel is healthcare professionals. Dr. Liz Worley, President of Pennsylvania College of Emergency Physicians, and Maureen May, President of Pennsylvania Association of Staff Nurses and Allied Professionals. Thank you both for being here. However you guys want to begin.
Thank you. Sorry, I worked overnight on Saturday night and it's still catching up with me. My name's Elizabeth Worley. Hello. I'm a board-certified emergency physician currently practicing here in central Pennsylvania, and I serve as the president for the Pennsylvania College of Emergency Physicians. Thank you for having me here today to support HB 1925, legislation that PACEP enthusiastically supports. Recently, national emergency medicine organizations came together for their inaugural All-Emergency Medicine AI Summit to prepare for how AI will transform EM education, research, and clinical practice, and how to do it responsibly. There already exists medically oriented AI-driven platforms that collaborate with medical organizations to ensure that evidence-based clinical policies and practice guidelines are available to physicians. You have my full written testimony, but I want to speak more personally today about what AI looks like in a real emergency department. The good, the bad, and the areas where HB 1925 provides exactly the right guardrails. First, AI helps us catch critical findings faster, which many others have already mentioned today thus far. But physicians still remain the ones making the decisions. A common example, as others have noted, is in radiology. Radiology departments may now use AI tools that scan CT images the moment that they are taken. If the algorithm sees something concerning, such as a potential intracranial hemorrhage or bleeding in the brain, it bumps that study to the top of the radiologist's reading queue. Just last week, one of our physicians in our organization described a case where a patient had fallen the day before. They were on blood thinners, but they went to CT with the nurse. without the physician present because the physician was taking care of other patients and they were completely stable. The AI system flagged a possible bleed and it notified the CT techs, the emergency physician, and the radiologist. All of these alerts show up in the imaging system, and it then permits the radiologist to read it earlier than they otherwise would have, and it permits the emergency physician to start any critical interventions as soon as that's available. And I want to note that it's not just necessarily interpreting the image, it's still up to the emergency physician and up to the radiologist to determine the type of bleed, which will dictate further treatment. As this is crucial, the radiologist still made the diagnosis, the emergency physician still made the treatment decision, and that's exactly how AI should work. It accelerates care, but clinicians remain in charge of the care. AI can also support interpretation, but it is imperfect and it must be overread. Some sites where my colleagues work use AI-generated preliminary reads on X-rays. Sometimes the AI gets it right, and sometimes it does not. Every single one of those images is still overread by a radiologist, and it still requires my colleagues to clinically correlate those possible findings. House Bill 1925 recognizes this reality where AI can support care but cannot replace the licensed physicians caring for the patient. AI also helps with documentation burden, but only the physician can finalize the note. As others have noted, one of our physician colleagues also shared that their electronic medical record now includes an AI bridge tool. It listens during the patient interview and drafts the clinical note, the entire history, assessment, even the medical decision-making that is rendered by the physician. But she still can edit it, she still decides what belongs in the record, and it saves her valuable time so that she can also be taking care of other patients concurrently. This is the kind of innovation that we want. Tools that reduce administrative load while keeping clinical judgment firmly in the hands of the physician. AI sepsis alerts also show the need for human oversight. They're a perfect example of why House Bill 1925 is needed. These flags often alert us to patients at risk, but they also frequently misidentify patients. One physician in our organization mentioned a patient that they had with COPD, and they had a sepsis alert fire in the EMR simply because of abnormal vital signs. The physician had to override the alert. We can see similar abnormalities in patients with a GI bleed. The AI algorithm can help screen the EMR for patients with findings of possible sepsis because it's important that we don't miss those patients. But it's also up to the physician to assess the encounter based on the clinical scenario in front of them. So we use our training to make a clinical decision and interpret the medical encounter because management of sepsis versus COPD or a GI bleed is vastly different. This is why the bill's requirement that a licensed clinician review, approve, and override any AI-based coverage or clinical determination is so important. And finally, AI can support point-of-care ultrasound. AI guidance is emerging in the setting of point-of-care ultrasound, which is a tool that we use every single day in emergency medicine. And the AI tools can help clinicians with probe positioning and identifying structures on the screen. It's especially important and useful in rural or resource-limited departments, and it can also be very useful in training our next generation of emergency physicians. But again, it is up to the physician to interpret and act on those imaging findings. So these examples all point toward the same conclusion. AI is already in the ED, and it can absolutely help us, but only if transparency, accountability, and human oversight are built into the system. HB 1925 strikes that balance, which is why we strongly support this legislation. It protects patients, it preserves physician judgment, and it allows responsible innovation to progress healthcare delivery. Thank you.
Thank you.
This one. Can you hear me? Thank you. Good afternoon. My name is Maureen May, and I want to thank you for allowing a nurse to come before the committee and speak for the frontline caregivers, the nurses and healthcare workers in Pennsylvania. My name is Maureen May, and I have the honor of serving as the president of the Pennsylvania Association of Staff Nurses and Allied Professionals, which represents over 11,000 healthcare professionals across the state. PASNAP was founded 25 years ago by nurses deeply committed to advancing patient-centered care and to safeguarding caregiver voices and protections, not just for our own hospitals, not just for our own members, but for every patient across the Commonwealth of Pennsylvania and for every caregiver. I have been a direct care registered nurse for over 40 years. In my time at the bedside through the ravages of COVID and the rapid corporatization of healthcare, PASNAP commitment to patient-centered care has never wavered as patient care has evolved. The tools around us have changed, though, but our commitment to our patient has not. And this is the lens through which bedside caregivers evaluate AI and why I am here today. Last week, ahead of my testimony here today, PASNAP surveyed our members about AI at the bedside. Individual replies varied by position or hospital, but there was one overwhelming theme. Healthcare workers are deeply concerned, profoundly distrustful, and almost entirely shut out of the decisions about AI at the bedside. A nurse in pre-cert shared this with us. The in-service regarding AI was less than 1 hour, and no feedback has been requested since the initiation of the new process, which could be dramatically changed. Minimal training, no checkbacks or regular evaluations, and no transparency whatsoever about how AI systems in healthcare are working or not working. That's what our members are experiencing, and that is not patient-centered care. In healthcare, innovation has served caregivers and patients should serve the caregivers and patients, not just the bottom line. And technology has to support, not replace, clinical judgment. The fact is, for many applications, like we've heard here today, imaging and analysis, AI is very good, much better than the human eye. But for many applications of AI in healthcare, has only an 80% success rate. That means AI gives the wrong result 20% of the time, which is a problem for us as caregivers. We need to make sure that clinical personnel are ultimately in charge of making clinical decisions, even if AI is in the mix. Our internal survey of 89% respondents said they didn't trust our employers to implement AI with patient safety and care at the forefront and priority. And that's why I'm here speaking in support of Representative Venkat's bill today. This distrust is not theoretical. It comes from what we've already seen. And at the bedside, I've been in direct care in hospitals for 42 years. When algorithmic acuity systems are used to assign staffing, it does not work. They consistently underestimate what the patient's needs are. Every nurse or any nurse who works with those systems say that their clinical judgment just does not match the computer's assessment, yet hospitals use those flawed numbers to justify staffing. Our members describe in-hospital transport systems that cannot recognize urgency. So a stat scan can be treated exactly like the same as a routine one. It happens to just go into the queue. Other members cited automated medication tools, which is the PICC system we use that at times, won't release the medications and holds back, and that's a delay of care. These systems just do not understand priority. They just don't get the context. They're a machine. They don't recognize a crashing patient. They don't know when a stat order should leap from the front of the line, from the back of the line to the front of the line. And when something goes wrong, the liability falls on us, not the vendor, not the algorithm, and not the executive who purchased the software. I am not anti-technology, nor are my colleagues. Technology helps us service every day and allows us to practice at a higher level. But as a committed advocate for patients and frontline caregivers, we have a responsibility to look at how AI is being used in our hospitals, to evaluate claims that AI will enhance our bedside practice and improve the quality of patient care, and to actively protect our patient rights to the one-on-one care, privacy, and safety that they deserve. When caregivers are removed from decisions regarding bedside innovation, it's patients and caregivers that suffer. AI must be regulated and challenged on an ongoing basis to make sure that it is learning and helping doctors and nurses and other caregivers, not hurting us. This has to happen both here in Harrisburg and at the bedside. We know from our experience that we cannot rely on our employers to make sure that this is happening in a proper way. If AI is going to be in healthcare, and it already is, frontline caregivers must be at the table, and the state must back us up in protecting the privacy and care of all patients. Implementation of an assessment, we need to institute AI assessment teams at every healthcare institution to assess where and to whom AI should be deployed, and assess its successes and its failures. Training. Caregivers who are being asked to use the AI need to be trained on how the AI works to be able to assess how to incorporate it into their clinical thinking. Caregivers need to know upfront, is this a fixed model? Is it not? Can it learn? Does it learn? What decisions are being performed? Does this AI, is it a black box? Because we know black box systems should be avoided when it comes to diagnosis and assessments. Protection of clinical judgment, and this is where my heart is. Clinical judgment and clinical staff. We need guarantees that AI will support and not replace clinical judgment. AI is wrong 20% of the time. There is no replacement for trained, experienced clinical professionals. That includes ensuring that clinicians are not held liable for AI mistakes. We need to challenge the tool. Given that the AI tool is 20% wrong most of the time, at that 20% of the time, we need to encourage our frontline caregiver staff at every institution in which AI is being deployed to challenge the tool, to override its decisions when it's appropriate or not appropriate, and in the best interest of our patients, and to teach it better. Privacy and disclosure is an issue. Tracking and surveillance is also an issue with us. We need institutions to be able to be transparent about the tracking of employees' behavior with AI and to what end they are doing so. Anytime staff are being recorded or tracked in any way, that needs to be disclosed. And protections, mostly for newer staff. Doctors and nurses and clinicians in their first 2 years of practice should not be using AI for their assessment and diagnosis purposes. From novice to expert, it's a practice that is built on many years of experiencing firsthand clinical judgment and looking at the patient and not looking at a machine. AI is here to stay in healthcare. The potential for improved outcomes is real. However, we need to recognize that the potential is not guaranteed. AI can either help us or hurt us. If our seasoned, experienced caregivers are not overseeing and teaching AI systems with sufficient training and protections, AI will fail in its mission and ultimately fail our caregivers and our patients. That's why PASNAP is in support of House Bill 1925. Thank you.
Thank you. Any questions? Bridget?
So thank you, and thanks for everybody for being here today. Clearly, this requires an enormous amount of discussion, AI and healthcare. You two remind me of Arvin and I, the nurse and the doctor. See them up there, the balance they need. So Maureen and both of you, I mean, both of the stories that you spoke about, but certainly I think in the panel one when it was James who spoke about training. You know, I see all the good that comes from AI and all the clinical, the time saving, the story that you told about the patient on the way to the CT, like all of the things that AI does that is a benefit for the patient, but keeping that patient center and the training. That's where I step back. I mean, you know, you're talking to somebody who did SOAP notes, you know, you're a little longer in the field than me. I'm 30 years. You're a little longer in the field of bedside nursing. But I want to know how we balance with training that human contact, that intellectual curiosity for the students to actually be learning about how to see and take care of patients and do that clinical evaluation of the patient, but using the tools that AI provides them to get better. So that's kind of, I don't know if that's a medical school, all the healthcare professionals, the medical school, the nursing school. Have we started, and forgive me because I don't know this answer, have we started to actually incorporate AI training and how you use that in your profession as you're being learning in school?
I have a colleague in emergency medicine that works with resident trainees. So they're physicians, but they're still learners, and they're training under experienced attending physicians. And they use AI currently as an adjunct. So they're still responsible for learning how to formulate a differential diagnosis in medical school. They're still developing the differential diagnosis for their patient encounters. But then they might use one of the AI tools that is evidence-based, that has input from our medical organizations to supplement their differential. What could they be missing? What about those zebras that we worry about in medicine that you might see once in your career? So I think it's an adjunct, but it still is up to the learner and for the physicians training them to teach them how to do the medicine first.
I'm not aware of AI being used in nursing. education yet. But we do have AI tools that I do use, and I'll tell you that we have a system where it's Epic, and we can use macros. Most of our nurses that are older, like myself, will not use macros, but all the younger nurses are jumping right onto the macros. And what's happening is we believe that the younger nurses are training the system by the input of the data that they're putting in, whereas we're older ones. We're not using the macros because it's not taking the macros and implementing it into the system. So I don't believe that the AI is being used in the training at all, but I do believe, like I said before, AI has great potential in many ways. I am a person that comes from, like, again, patient relationship-based care. And we want to do the right thing, and I know that everybody wants to do the right thing, but AI can go wrong, and that 20% that is in there is frightening. And also, we learned that when there is information that is not proper, or it goes in, there's this thing called a hallucination. I don't know if you've heard about that, into the system. So it's a piece of information that is filled in by the system and not by the clinician, and they call that an AI hallucination, which is pretty scary. When you think of that, that's what the systems are calling a mistake in the system. But it takes in that information and it uses it. So I don't know enough about AI, but I do know it's not being used clinically, and even for being a steward of sepsis and antibiotics, I think that's great that we can use that, but we still have to look at the data ourselves, and we do have to look at the patient. And that's really where we come from in support of making sure that this bill goes through.
I do think it can also supplement one of the features that we train our learners in emergency medicine, and that's not just patient management, but it's department management. I'm sure you're all aware of the crisis in healthcare and emergency department boarding. And if we can facilitate the diagnosis of a patient and initiate management or initiate transfer sooner, one, that is a patient-centric response for that one individual patient, but then it also opens up the bed for the next patient, the 30 in our waiting rooms in the evenings. And so our learners are now, I did not necessarily always get that training 20-some years ago, but our learners now are learning how to manage departments, and they're using the tools available to them to facilitate care for everyone and not just one individual patient as well.
Thank you. I don't know if Wax is still here, but his question was, Representative Waxman was, I think, the most balanced. Like, how do we utilize this for the outcome of the patient? That's the most important person in this whole healthcare system, is our patients, and how do we utilize this best with the balance? So these kind of hearings are really important, but certainly require more discussions. Thank you.
Thank you, Representative Day.
Thank you. Thank you, Doctor, for your testimony today. And Ms. May, absolutely outstanding testimony. Thank you for your testimony as well. And I was curious, I wanted to ask you, I hear many stories from nurses, including my daughter just on Saturday night. So, and she talked to me about, she's a newer nurse. She doesn't have the amount of experience that maybe you do or the doctor does. But the frustration of when you're reading something from a patient and that nurse-physician team that you go back to the physician and you're trying to manage each patient and the department that you have under your priority and under your direction. Do you think that AI and this huge knowledge base can help nurses with that sometimes frustrating, where a physician might not have time in the ER to educate you? Do you think that, or educate the nurse, not you, but the nurse, do you think that AI will be able to educate nurses on maybe why the doctor is not doing something more at that moment, and maybe even vindicate your feelings about the patient to move quicker to bring in the next solution?
So I'm going to give you an answer. It depends. That is an easy answer to give. It really depends. We use, computers. I was here when computers came in, and there was like this, we were weary about that. But I do say that there is that could possibly be part of what happens with AI. I don't know. But I do know that when we have the Epic system that we use, it does give you prompts. There are prompts that are very important, but you can't just look at those prompts. I know because I still work at the bedside. You cannot just look at those prompts. And And there's always an opportunity. AI is, you can access anything from a computer. You know, I can look up a white paper or a study, but that doesn't, how will that fit into a physician teaching me what we need to do in real time? We need to learn how to do what we need to do in real time and use, as Dr. Worley said, use it as an adjunct to the care that we provide.
Thank you. As I said, I just educated but also vindicated sometimes. So thank you, Chairman.
Thank you. Representative Ledbetter?
Thank you, Mr. Chairman. Dr. Worley, Nurse May, thank you so much for joining us this afternoon and sharing your valuable testimony. I will speak briefly to some context and then direct my question to both of you in the nature of preserving time. I think back to my childhood in the early 90s when computers and the internet was all the rage. No one really knew exactly what it was or what it was going to do, but everyone was able to talk about it. In a similar manner, I think to the early 2000s when my uncle got a Palm Pilot and it was the coolest thing. And if you had a smartphone, maybe you were kind of important because you knew how to do something that not a lot of people knew how to do. And now we're here discussing AI, and we're talking about AI being implemented in the healthcare industry or within a medical capacity. And so I want to thank the good gentleman who is joined with me on this committee for introducing this legislation. But my question to the two of you is that when we consider our roles as elected officials, we have to consider two cohorts in Pennsylvania. Not cohorts that are higher in priority, but certainly cohorts that disproportionately impact the Commonwealth. The first is agriculture, which I won't direct a question to given the backgrounds of both of you, but agriculture is the #1 industry within Pennsylvania, and it is the #1 industry in the 109th district for where I'm honored to represent. However, the second cohort that we have to consider are older adults, specifically those over 65, because that represents the largest demographic within Pennsylvania. And the cohort of 75 to 79-year-olds is actually the group that has grown the fastest from 2020 to 2024. And both of these groups or cohorts, the agriculture community and our seniors, while perhaps intimidation is too strong of a term, certainly have expressed concern over AI. And yet, as you guys have shared with us this afternoon, AI is already being used within the medical field. So in geographies like mine, where healthcare deserts are certainly a reality, and distances to clinicians and healthcare providers are something that impact seniors, what would your feedback be to concerned seniors so that we can reassure them that this is indeed not some big scary thing like the seniors of the early 90s or the early 2000s might have thought of smartphones or the internet, but it is something that we actually need to continue to be open to considering so that way healthcare can improve and ultimately the care that they receive improves.
What I tell my parents is that it's another tool in the toolbox. When I trained on paper charts in my residency, but we had Palm Pilots in medical school, so I completely understand your reference there. And I remember being forced to memorize an equation that I then had to use on exams in medical school, and they wouldn't let us use our Palm Pilots. And they said, no, you had to memorize the equation. What I really need to know is when to use that equation and how to interpret that equation. Not, can I pull that equation out of my head? Probably somewhere in the recesses of my brain, but really I can still use it. I know where to find it on my phone, on an app, and I know how to interpret it clinically. And so I use that example because it's a tool. It's just another tool in our toolbox, and it's going from a hand crank drill to a power drill. So it's an evolving tool that's going to continue to grow if we use it with some safeguards in place, and it's going to improve with clinical practice, and I think it can only expand our capacity to care for patients. I give another example. I have previously worked minutes away from the Philadelphia airport, so I have to worry about infectious diseases here in Pennsylvania that we see commonly. They're different than some infectious diseases if I have a patient who just came from Arizona or the Midwest who lives on a farm, since you were speaking of agriculture. Well, living or practicing near an airport, I had to worry about foreign medical diseases, and I may have only heard about them very briefly one time in medical school. So there, I would use it as a tool, think of my typical differential diagnosis, and then say, what am I missing based on where this patient just moved from or where they traveled to? And again, so just using it as a tool in the toolbox, and that's the analogy that has worked for my family members.
Thank you, Dr. Worley. Nurse May?
Yes, as a tool and as an adjunct. I mean, this is not what provides the care. It's the physicians and the nurses that have hands-on direct care. They're the ones that their eyes are on the patient. We are the ones that are here to protect you. And this is, again, as the wonderful doctor has told us, an adjunct and a tool. And that's how we use it, just like we did when computers came in. We were really frightened about computers. How is that going to change care? Are we going to be at a computer longer than we're going to be touching our patients or putting hands on? If you are concerned about that, what you're more concerned about is making sure that you're getting the proper care. And by having clinicians and people there, providers to care, is number one with the adjunct and the tools that we have to do the work that we need to do and to provide proper care.
Thank you both very much. Mr. Chairman, I think it's clear that rather than accept a binary proposal of pro-AI or anti-AI, we can all continue to be pro-Pennsylvania, and I appreciate the testimony today. Thank you.
Thank you.
Thank you. Representative Venkat?
I just wanted to say thank you to my fellow clinicians for testifying today. I know this isn't where your normal comfort zone is, so I very much appreciate it. And I would just emphasize to my colleagues here in the Capitol that what we're hearing from clinicians is not that this is, to borrow from Representative Ledbetter, this is not pro or anti-AI. This is making sure that there is transparency to the public, that we continue to have a human decision maker, especially where AI is a black box application, and making sure that with this novel technology that has unique characteristics from other medical circumstances, that we can provide reassurances to clinicians, to the public, to patients, that existing laws related to privacy, safety, are still, and anti-discrimination are still being complied with in our delivery of healthcare. So I just wanted to say thank you.
Thank you. Any other questions before we move on to the next panel? Thank you all very much. So now we've come to our last panel. These are our insurers. We have Jonathan Greer, President and CEO of the Insurance Federation of Pennsylvania. Megan Barbaro, Executive Director of Government Affairs, Insurance Federation of Pennsylvania. Aaron Smith McClellan, Director of Data Science and Health Outcome Research, Independence Blue Cross IBX. However you guys want to go.
All right. Thank you, Chairman Cerisi and the members of the committee. My name is Aaron Smith McClellan. I'm the Director of Data Science and Health Outcomes Research at Independence Blue Cross. I'm also one of the co-leads of our Generative AI Center of Excellence. And I think one thing to say right out is that we are very much aligned with the intent of this legislation, with the goals to promote transparency and accountability, to avoid perpetuating historical inequities and biases and creating new ones. In fact, we're on the record as we published a paper in, I think, 2022 on the importance of health plans identifying and mitigating bias in healthcare algorithms and the use of AI in healthcare. So we're very much aligned in that. And of course, ensuring the integrity of human clinical judgment. And I think this conversation is critical because, as we've heard, AI does hold immense potential in healthcare and improving the health of Pennsylvanians. And our top priority and our mission really does revolve around our members, right? The access to care, timely, affordable health care, improved outcomes, and navigating the experience in the healthcare system, which, as we know, can be challenging, and of course, patient safety, member safety. At Independence Blue Cross, we've been developing and deploying AI systems for about a decade. We have a large number of clinical models that help with disease identification, identifying and predicting when we might expect exacerbations of disease or acute clinical hospitalizations that could be avoided. In one of our populations, our Medicare CHF business, or line of business, and those members, we have a likelihood of hospitalization model for those members, and we've seen a 38% reduction in ER visits. We've seen reductions in hospitalizations, reductions in medical costs, and this is driven from the use of predictive models to identify risk, integrate with our care managers who make outreach calls and sort of keep people out of the hospital, which is exactly the kind of thing we want AI to do. And we do appreciate the intent of this legislation, as I mentioned, but also there are already numerous protections in place that address the concerns of this bill in the form of, as Commissioner Humphreys mentioned, Act 146 that already explicitly requires human oversight of clinical decisions. And the BCBSA has already said that, this is something that they're requiring of all plans. This is something that is already required. We're already doing it. We already will do it. We'll continue to do it. And there's the PA Bulletin and the NAIC frameworks that are coming out are very comprehensive and very robust when it comes to governing and managing and describing and being transparent about the kinds of about the entire AI program, not just around utilization management, right? It's a very comprehensive framework. And we think that individually and collectively, the protections that are already in place in this very regulated space really already accomplish the primary goals of this bill. I want to take a moment to talk about a couple specific aspects of the bill that I think could benefit from some clarity. As my colleague from CHOP mentioned already, the definitions of AI could be a little bit more clear. They don't, and actually, I think our colleague from the Attorney General also mentioned the risk of having too many different definitions of AI and AI systems and so on. The HB 125 definition is kind of a process-oriented definition. It describes like how AI systems work, perceiving, abstracting, interfaces, things like that. I think the Pennsylvania, the PID, the definition of AI in the PID bulletin defines AI by its capability to perform tasks that are required that require human intelligence and like learning and reasoning. I think this approach is more technologically neutral. And as technology changes, I don't think we want a technology-based definition of AI, right? More of a capability-based definition. I think that echoes what my colleague from CHOP was alluding to as well. Also, another kind of concern is some of the bill's requirements might be ill-suited for the generative AI use cases that we've kind of been discussing here, and it's not differentiated from requirements from other traditional AI use cases. For example, there is a requirement that plans, quote, supply a logic or decision tree of artificial intelligence-based systems. So this could be interpreted as providing documentation related to the inner workings of the AI algorithm, right? Or documentation about the process in which it's used, right? So if it's the first one, it's very difficult or impossible to do, right? If we have a large language model like a ChatGPT kind of model that's reasoning over documentation, reasoning over medical records, medical claims, things like that, that's reasoning over these things, and we're using like a ChatGPT model for that. One reading of that part of the legislation requires us to give you documentation and logic about how the AI is working. Of course, none of us know that, and none of us can get to that. Another interpretation of that is that you're interested in the process, what happens, right? What data go in, where's the AI applied, what decision points are made, what decisions are made by AI, what decisions are made by humans, and that's very reasonable. And if that is the interpretation, that is already explicitly covered in the PID bulletin. There's very comprehensive language around what has to be supplied in terms of the models of the entire AI system, all of the documentation, everything that goes in, everything that comes out. So that's the just room for clarity there. Also, there's a requirement in the bill to provide a description of each training data set used by artificial intelligence-based algorithms for clinical decision-making, including the source data. Again, in terms of the training of the model, right? If we're using a large language model, we don't necessarily know what data were used to train those models, right? Those models are trained on all of the information that's been written, right? Like tomes and tomes of information. So we can't really explain that, right? If it were a traditional machine learning model where the data scientists sort of have control over, these are the data that go in, these are the medical claims data, these are the pharmacy claims data, here's the lab data, and then we use AI to identify the patterns that exist within the data, right? Because that's what we're trying to do, like classify somebody as, will you have an acute exacerbation and go to the hospital or not? So we're using AI to figure out if that's going to happen, and then we can validate the outcomes. In that instance, yes, we can kind of describe to you the data that go in and verify that, but it's sort of not the case with the large language models and the basis of generative AI. So from a compliance perspective, from following the letter of this law, it really does depend on the interpretation. I think the law could really benefit from some clarity on those particular points. We'd also like to address the complex challenge of regulating third-party vendors. I think, again, our colleagues from CHOP mentioned this, but as licensees, for us to fulfill the compliance obligations that the commissioners already rightly opposed on us in the bill, there has to be a mechanism to ensure that our vendors provide the necessary information for us. A lot of times this is proprietary information. What data are they using? How are they using it? What bias and fairness tests have they done on their own data? Right? We can ask them, but it's challenging to get that information from them. There's no teeth out there for us to actually require that of the vendors, right? Yet we would be required to supply that. So I think that that's an area for exploration. Again, we agree that there's a need for smart regulation of AI to provide protections for all Pennsylvanians, but those regulations also should be across industries. To the extent that there is a need for healthcare-specific legislation, it should align with existing definitions and regulatory frameworks and avoid imposing undue compliance standards that we already have in a very highly regulated industry. Again, we appreciate the committee's work on this bill, and we look forward to working with you and seeing how this could be better.
Thank you.
Good afternoon. Again, excuse me, my name is Jonathan Greer. I'm the President and CEO of the Insurance Federation of Pennsylvania, and joining me is Megan Barber, who's our Executive Director of Government Affairs. One of the going last in a 3-hour hearing is both a challenge and a virtue. So the challenge is, how can we tell you something that you haven't already heard? The virtue is I get to say, yeah, but everything Aaron said we agree with. But in terms of trying to tell, I will not read our prepared comments. What can I tell you that you haven't heard? And I want to respond to a sentiment that occurred earlier this afternoon that we can't wait for a national model. We can't wait for Congress to act. And it was something that Representative Ledbetter said, that he hearkened back to what I'll call the early days of the internet. And this was novel technology, as AI is now. And how are we going to do this? How are we going to harness this? And in response to that novel technology at that time, Congress enacted something called UETA, which is the Uniform Electronic Transactions Act. It allowed for states to do the same, for state-governed transactions. Pennsylvania did that right after, and this was in 1999. So this was at the very beginning, maybe not the very beginning of the internet boom, but it was early, and Pennsylvania followed suit. But the most important part of that legislation, both at the state and the federal level, was the term uniform. You need to have uniformity in whatever you do to govern this technology, because if you don't, you've got to have differences not just amongst states, but amongst industries within states. So for example, this bill is specific to healthcare and health insurance. Okay, what about banking? What about the practice of law? What about engineering? What about architecture? There's going to be different terms and different terminology and a different construct, presumably governing all these different forms of labor or practices. That's a problem. And and whatever we do here, you heard a little bit about the technology, or I'm sorry, the terminology. It's not uniform, what we have here. And that's going to put Pennsylvania at a disadvantage. States, we talk in our comments about this patchwork effect, not just among states, but within states as it relates to industries. That's a recipe for disaster. You want to have it be a uniform construct that applies nationally. Now, whatever your thoughts are on the Trump administration's EO on AI, that's going to, some states will say, you know what, we're going to do our own thing. And some states are going to say, we're going to listen to the Trump administration. There will be a patchwork effect because of that, whether we like it or not. That is what we're trying to avoid. That is why Commissioner Humphreys, when you heard him today, he is a leader on this issue at the NAIC. I'm not suggesting that it's easy. I'm not suggesting that it's not a challenge. It is. But I think what you heard from him today was a real firsthand knowledge of this issue as it relates to insurance. But it has to be part of a uniform process that applies across not just states, but across industries. Because if you don't do that, you're going to have this conflict that's actually going to undermine all of the virtues that AI is going to produce through efficiencies and innovation. That is our greatest concern. So, Megan, I don't know if you have anything you want to add.
And I would just also add from the company-specific perspective that some of the companies that we represent also span multiple states. And so the challenge that would present for companies who operate in states other than Pennsylvania and potentially put them at a competitive disadvantage.
So we're happy to answer any questions.
Anyone have anything? You again? Yeah, go ahead. I was kidding.
So first of all, thank you for your testimony, and I very much appreciate it. I want to talk a little bit about this patchwork effect, because we've already seen a number of states who have legislated. We heard from the Attorney General's office today that they believe that there is a need for state-level regulation, and healthcare specifically, which is the subject of the legislation in this hearing, is highly legislated and regulated upon at the state level. I mean, I would argue as a health professional that the presumption is that state-level regulation is the primary area where healthcare is regulated. It's a relatively new phenomenon that the federal government is getting involved. Putting aside the merits of the president's executive order, because I think there's a real question as to the constitutionality of that, and clearly there's no consensus from Congress about that. But given that we already have a number of state-level pieces of legislation, so the patchwork effect issue, that horse is out of the barn, and that we recognize in Pennsylvania that healthcare is a state domain in terms of regulation, tell me exactly why this legislation would tip the apple cart, so to speak. Why would it all of a sudden create the dramatically concerning circumstances that you're raising?
Well, and the UETA example is a good example. There were states that had done electronic transaction acts prior to the enactment of the congressional law. The reason that Congress stepped in was to avoid that because of commerce, interstate commerce. They didn't want different states to have different electronic transaction act regulations, and that's why Congress stepped in. Now, states could come in for their own, and Pennsylvania did, for Pennsylvania governed transactions. But for interstate purposes, that's why. That's why Congress did it. And they did it in 1999. So it didn't take them that long. I mean, let's say that we all got Windows 95. I think I had Windows 95 one time. That was early on. So within let's say the internet had been in use by, let's say, 5 years. I don't think we're 5 years into AI yet. I mean, I understand the desire. AI has been around, but in terms of ChatGPT just went live, 2 years ago? So we're really at the very beginning of this. We recognize the concerns. We recognize the desire for responsible use of this technology. We share that. We want it to be, it has incredible potential so long as it's used responsibly. We agree. The question is, how do you determine and how do you govern responsible use? That is why we think it's best done at the federal level, or if not the international level. Because if individual states are allowed to do it amongst themselves, you will create friction. And you will create problems, as Megan said, for interstate companies that work in and outside of Pennsylvania. Okay, we have 2 different laws on AI and healthcare or health insurance, and we're a 50-state company. It is made for a federal fix. Now, I share the concern. If we wait for Congress to act, we're going to wait for a long time. I'm not sure, because the history is that they did act relatively quickly in the late 90s in a similar way.
Thank you. Representative Day?
Thank you, Chairman, and thank you for your testimony today. I really appreciate. I'm going to try to take maybe 3 large questions and get them as small as possible, keep us going in this long hearing and not hold us up too long. But generally, can you describe how AI is currently being used? You're here before us today. You're talking about it being early in the process. I understand all those arguments. I also understand what the maker of the bill is trying to accomplish here. And I've made previous comments today about getting out in front of and making sure that AI is used for the betterment of the end user, the customer or the patient in the healthcare realm. You could talk about it in other parts of insurance as well if you'd like to. But really today we're focusing kind of on where it is in healthcare. And what I'm concerned with is what I personally see is when I go out with a provider, that blanket signature that you give that says, if this is not approved by your health insurance, you're going to be responsible for it. I'm concerned that people are going to be left holding the bag, where the provider is going to provide the process, the solution that they think is going to help you save your life, make your pain go, whatever it is, make you healthier, make you better. And then because the patient signed that the provider's going to have no other cause if the insurance denies to do that. And we have, I've gone through in my years here all the, it almost needs to be reworked the way that process works. You get a letter before you even get a decision, and that we'll set that aside for right now. But I'm concerned about this process actually making that even worse and leaving the bag being held by the end user. So back to my original question, how is AI being used in the process? And where are they? Earlier, I had said, I think the human person should be in the appeals end, but could you tell us exactly what's happening right now and maybe where you see it going in the immediate 6-month to 8-month future?
We'll start. Let me, Representative, if I may, let me first answer by telling you how it's not being used. It's not being used for clinical determinations, prior auth, things like that. It's not being used for coverage determinations. Its greatest advantages is in the area of identifying fraud, waste and abuse, administrative issues, discharge releases and things like that, and care management. Those are where, and it is. I think one of the providers said earlier, it's a tool in the toolbox. Yes, that's a good. It's a very sharp tool, but the decision is being made by a human in terms of the care that's being rendered. It may be assisting with that process, but the actual decision is being made by a physician.
Making a brief comment about your comments, our caucus for 15 or 20 years and probably longer has always been about waste, fraud, and abuse and using all dollars in the public realm appropriately, so we appreciate that. But Doctor, did you want to answer that original question?
Thank you very much. We've been using AI for a long time at our company, and I alluded to earlier a lot of the clinical models. These are more traditional machine learning models for predicting the likelihood of hospitalization, likelihood of ER visits, disease exacerbation, things like that, primarily. Maternal risk, things like that. On the generative AI side, we have an agent assist bot that we built for our customer service agents so that they can actually type natural language queries in to help get responses that are related to their benefits and medical policy as they correspond. When somebody calls in, is this covered or not? So we have but our agents use them. They're talking on the phone, right? We are building processes for member summarization for our nurse case managers. They, before they make an outreach phone call, these are tens of thousands of calls a year. They spend a lot of time reviewing the records of the members, right? What surgeries did they have? How far back did they want to go? What medications? What happened recently, right? To get a clinical picture. That takes a lot of time. So we are using large language models to reason over all of that. And we work very closely with the nurse case managers to say, what do you want to see? What is helpful in here? And, you know, it's a process where we pull that information back and we give that to them and they say, this is not what we want. And we look at like what's actually up there for the member. This is not what I would have pulled back. So there's a process that we go through. It's not just, you know, some of the testimony and conversation here made it seem like it's the Wild West, right? Like, oh my gosh, you just throw all this information in there, it's a black box, and you get an answer. Look, clinical decision, chaos. That's not how it works, right? Like, there is a lot of testing that happens. There's a lot of verification that happens with these models. When it comes to, you know, I think you were referring to utilization management review. It's the same, it's a very similar sort of process. We get information in from the providers, right? And that information is only as good as the providers give us. And sometimes it's not very good. Sometimes it's not complete. Sometimes it's, you know, and we have to keep going back and forth with them. That's sort of the nature of how this operation works, right? Same thing. It's tens of thousands of instances where people are requesting access to injectable medications or surgeries or what have you, right? People have to read through this information. How can we summarize this? And how does it correspond to the medical policy, right? What does the medical policy say? The medical policy says that in order to have this treatment, you have to have evidence of this diagnosis, not that diagnosis. You have to have ruled this out and be tested for this, right? And we get this information in. We can use AI to pull out very clearly what are the 5 things that this policy requires, and where's the evidence that this meets or doesn't meet this, present that to the clinician, and they have the information there, and they can go and check, right? So that's sort of like, that's an AI process that we don't have currently, but that's sort of what all of the vendors that we talk to, that's the way that we approach looking at that as well. So the clinician is always in the loop like it has to be.
Thank you for that answer, and I think Mr. Greer would probably echo this. I'm probably one of the strongest supporters of the insurance function in the legislature, just because I just think it's a really important function. A lot of times, the insurance industry takes a lot of flack. But I do want to say the prime sponsor had stepped out, and you know, I support everything that you just said because I believe in the insurance function. The prime sponsor is actually stepping forward on government's role of oversight of what you just said. So he's trying to come in to give oversight. So a lot of what you just said is trust our process. We do trust, but we like to have an oversight
Trust and verify,
function.
right?
Yeah.
But I mean, the PID bulletin is very, I don't know if you've read it. It's pretty detailed and pretty onerous. As like, I am the practitioner at our organization that needs to go through and say, all right, here's the 45 things that he says that we have to do for every single model, right? And for all of the communication with our stakeholders, all the verification, all the bias testing, our bias testing frameworks for every model, the data, right? We already have to do this.
I appreciate your answers and being here and everything that you talked about, and you're going to be an important part of Pennsylvania deciding this policy moving forward. So thank you all.
Thank you.
Well, seeing there's no other questions, I want to thank you, this panel, for taking these questions and your testimony. And to wrap it up, I want to thank all those that testified. We've heard some very interesting testimony. And like you alluded to, this is the beginning of what we're going to look at. And I would hope that the federal government would move, but sometimes the states need to be moved first, and maybe the federal government would wake up and do something, because right now there is a lot of willy-nilly that exists because the federal government is lollygagging. And you know, AI has been here a while. Maybe we're starting to see it a lot more, but every one of our districts is seeing data centers come in. We know that's a compiling of information. It's only as good as the information goes in, what comes out. But we all have to remember the personal touch, because I'm the first one to say, I don't want a computer telling me my answer or speaking to me. I don't want a computer sounding like a human and spewing out something and confusing a human to know, am I talking to someone that's real or am I not? Even the way that it pauses. And we don't need to hear that typing thing when you're asking a question either. We know it's a computer. There's no computer going like this. So when we hear a lot of this, there's a lot of the confusion that we hear in AI, and this is a lot of the non-trust that we have. And we want to see a physician and not someone who just read it off a file because the computer generated it. And I know years ago when we had been denied an insurance claim from an insurance company that didn't even look at the claim because the person on the other end of the phone made a mistake and put me on the speaker rather than muted it and asked the person next to her why it was denied without looking at it. So there's a lot of distrust in the way this all goes down. And we all know that a diagnosis of 200, a serious diagnosis can cost industries millions of dollars. So I'm glad to hear that you're willing to work with our physicians and everyone that was here today. But I think that we have to hear from the frontline people, like our doctors, who the bill is coming from, like our nurses who are here, who are standing with the patient. I don't want to hear statistically. I want to know that this is the treatment that we have to have. And I think, again, the federal government has to get involved. And to say, well, we need the feds or international to be involved is great, but they're doing nothing. And to do nothing is not an answer. Congress needs to act. An executive order saying that the states can't do anything is not acting. That's consistently doing nothing. So I thank our sponsor of the bill. I look forward to working with all of you as we move forward, but knowing that there is a major frustration. It's not just in this area, it's across the board in AI, that Congress has, fallen behind. This is something we should be in front of because it's only going to get worse in some of these areas without direction. So thank you. Thank you all for being here for 3+ hours. We didn't take a bathroom break, so I'm sure everyone's going to rush to the bathroom right away. But thank you all again, and for our staff that put this together, thank you.